but one of the two key things are, yeah, if you have your camera off unless you're speaking, and obviously be on mute, and then I'm sure you'll do what I did, which is you leave yourself on mute when you're supposed to be speaking. Right, okay, so welcome everybody. We'll get kicking off. Nikki started recording the meeting. So yeah, welcome. I'm Graham Hoskin. I'm chair of the Health and Wellbeing Board. So very pleased to welcome you all today. As you can obviously tell, we'll continue these on virtually through Teams rather than via in public meetings. I think that seems to be a very sensible thing to do, bearing in mind the state of the pandemic at the moment, particularly those of us who have secondary school kids mixing and spreading the virus around. So you don't want to be in a room with me at the moment, I can assure you. Right, I'm going to read out this chair's announcement, which is, I'd like to inform everyone present that this meeting will be recorded on Microsoft Teams and will then be uploaded and available for repeat viewing on the Council's website. Council's officers and partners attending will be asked to introduce themselves before they speak at the meeting for the benefit of the public. To help me manage the meeting, if any members of the board wish to speak, please can you indicate you wish to speak in the chat section of the screen and then wait to be called. When you're not speaking, if all attendees could have their microphones on mute and switch off your cameras, and when called to speak, please switch on your camera and unmute your microphone and pause for about 3 seconds to allow for the slight time delay in connection. If you're addressing the meeting, it would be best if you can have your camera on so that people can see who's speaking. However, we're aware that we are at the mercy of individuals' broadband services, so it's possible that loss of connection may happen, or if the connection is poor, you may find it improves if you turn your camera off. So we'll understand if that's necessary. Yes, the most important thing then is, because there's so many of us here, I'm not going to go around everyone introduce themselves. If you introduce yourself when you speak for the first time, that would be fantastic. So, Nikki, well, actually, I'm going to say Nikki because, well, yeah, we've got apologies. It's not on the agenda, and I say that every time. What apologies do we have, Nikki?
Yes, we do. We have apologies from Shona Douglas, Paul Illman from Fire Service, but Gail's here, and Teresa Wiles from BHFT. I haven't had any others, so if anyone else has got any apologies, then do let me know.
Okay, thank you. I don't. Okay.
Did we want to ask Francis and Sue to switch off their cameras so that we're not taking up broadband?
Yes, if you could, Francis and Sue, switch off your cameras until you're called. You will be called soon, Francis, to answer your question.
Thank you.
Okay, thank you. So the first item is the minutes of the meetings held on the 16th of July. I'm not planning on going through them page by page. People have had hopefully got the opportunity to see them. If anybody's got any points they want to raise or any accuracy they wish to raise on this, now's your moment. I'm not seeing anybody indicate. Oh, I am. Mandeep.
Hi, Graham. Thank you. Mandeep from Health Watch Reading. I was just wondering, Chair, if we could follow up on taking the hanging on report about GP access forward to a future ACE committee. I just wondered if you had an update on that, please. I know that continues to be a concern and the debate has moved on significantly in terms of pressures within the system, but also we've had a really good response from some surgeries who've taken some really positive action in terms of listening to patients and trying to make access better. So I think there's a lot more to report on.
Yeah, no, it's a good point. We're having conversations around that. One of the items that will, I'm hoping expecting to come via ACE includes the same day access review that's going on, and clearly whilst it's not the same thing, it's very closely related, isn't it, in terms of access to primary care and how you achieve that. So I'm discussing with the chair about how we could possibly have those in some way combined. So I think you're absolutely right. Access to health services, GP practice, telephone, all the rest of it, I think is something that's really interconnected and makes sense to look at in the round. So thank you for raising that, and it was on the action we have noted, and I completely agree, it's a really important item. Okay, thanks. Anybody else? No, in which case we'll sign those off. Or are you ever going to get me in, Nikki, to sign hundreds and hundreds of pages of minutes? I think we're signing. Hopefully we don't have to do that. So anyway,
yeah, when we first meet in person, I suspect.
Right, okay, so the next item is questions, and we have two for Mr. Tom Lake. Mr. Lake, I think both of your questions, I'm going to ask, I haven't got them in front of me, but Katie Summers, I think, of the CCG to answer your questions, as what you're asking is directly related to them. So, Tom.
Thank you. First question. There have been discussions for several years about a new GP surgery for South Reading, which is sorely needed. We understand that a site has been offered on church land. What progress has been made towards providing this facility, and when will it be operational?
Thank you, Tom. So I'm Katie Summers. I'm from Berkshire CCG, where I'm Director of Place Partnerships. So I'm here to give a response to your answer as such. So the CCG is currently working with general practice providers and a local church in the Whitley area, as Tom has actually said. And that is about development of a new practice site that would provide new premises for an existing provider. At this point in the development process, commercial sensitivities means that we cannot share further details at this point, but all parties are planning to have arrangements in place to consult more widely with interested parties in the very near future. I don't know if you have any subsequent questions for me, Tom.
Sorry, I was trying to unmute myself. Yeah, thank you very much, Mr. Lake. Tom, do you have
no, I think if it's in the very near future, I think we'll look to that consultation then. And thank you for the answer.
Okay.
Thank you, Tom. Right, you again.
Second question is about related to the consultation on urgent access. So it introduces queuing theory. Queuing theory is a facet of probability theory which helps us understand how well we can satisfy a variable demand, a random variable demand with given levels of service. For example, it tells us under plausible assumptions that if appointments are just sufficient to meet demand, then queues will grow linearly with time, owing to the randomness in demand, expected queues, that is. This branch of mathematics explains why we need spare capacity in hospitals and in primary care. If we're going to provide spare capacity for several streams of demand, several streams of the same demand, it's most efficient to provide it in common so that some of the variability smooths out. Berkshire West CCG is currently conducting a consultation, of course it's closed now, but it haven't had the results yet, into the need for same-day urgent primary care, including providing a central walk-in service at Broad Street Mall practice. Can we be sure that the CCG will take into account the efficiency and value for money arguments suggested by queuing theory and provide an efficient central overflow service for Reading, or will overflow continue to default to the Royal Berkshire Hospital? Thank you.
Okay, thanks, Tom. So thank you very much for your question. So it's really pleasing to see that 520 people have actually taken part in the survey and the engagement exercise. And I'd also like to thank Mr. Lake and his colleagues for helping spread the awareness of the survey and for handing out paper copies for those who are unable to access the survey online. The engagement exercise is intended to support the CCG in deciding whether the walk-in service is required in the near future, or whether on the day demand is best provided by a registered general practice who may work collaboratively, or whether or not alternative services required, such as ED streaming, or sorry, I shouldn't use abbreviations, emergency department streaming. The survey has also helped raise awareness of alternative options available to encourage appropriate use of range of services available across Berkshire West and to prevent default to the Royal Berks Hospital. The latest figures show that around 100 people go to the hospital emergency department every day and that they are cared for and treated elsewhere. Others contacted their GP for an appointment where there are local high street pharmacists who have highly trained health professionals and could help just as well. Work on appropriate use of services and accessing primary care, along with promoting self-care messages, are key themes for our winter communication strategy. And this is also to note here, we've done a lot of work quite recently in promoting about how people can get greater access to actually GP services going forward. I would want to add to this actual response to say, obviously, this doesn't necessarily respond to directly what you were saying here, Tom, in the fact that actually you were asking about the queuing system, but I'd want to make you aware that actually the primary care team are actively looking at the actual queuing model as it is at the moment, and obviously they will work with yourselves and the wider community to ensure that that is taken into consideration.
Thank you, Katie. Do you have a supplementary, Tom?
Well, just for information, really, as thank you very much for that answer, Katie. Since you mentioned the emergency department, it used to be the case that the emergency department was a much more expensive option for the CCG than a visit to a general general practice primary care. Is that still the case, or under the new integrated system, will those considerations be completely different?
Under the new integrated care system, one of the key things that is changing is the looking at the actual cost base and the payment mechanisms to hospital services. Hospital services used to be what's known under as a payment by results model, but I do know that is actually actively being considered. And one thing that is being looked into is more of a population health budgeting system going forward. So it is up for debate at the moment. I would actually want to recognise also for primary care colleagues here that actually at the moment, one thing that we do tend to do is actually only cost out in primary care those clinical episodes. However, the work of primary care has substantially changed following COVID, and their workload has significantly increased for doing online management as well, which is probably an unmasked cost at the moment. So in response, Tom, I think generally the whole of the actual finances is up for review at the moment. So I can't necessarily give you a clear answer on whether or not that is going to be a higher cost or lower costs than general practice at the moment.
Thank you. I think that was very informative for everyone. Thank you very much.
And thank you for your questions, Tom. So we now have Francis. I think I've kind of got the agenda in front of me, which yes. So Francis Brown, it's your question.
Thank you for taking the question. My question is, the question is about the South Reading surgery and patient experiences as reported in the last 5 annual Ipsos Mori surveys of patients registered at GP surgeries in England. One of the key questions is about overall satisfaction with one's GP surgery. Results over the last 5 years have been consistently disappointing. Between 96 and 99% of surgeries were rated by patients, that's surgeries elsewhere in England, as being better than South Reading surgery. The next survey will be in January 2022. Are there any reasons to expect improved results for the South Reading surgery? What actions have been taken by the CCG and and Reading Borough Council to help the surgery achieve improvements in its performance?
Okay, thank you, Mr. Brown, for that question. South Reading surgery, along with all Berkshire West practices, have experienced something like a 30% rise in demand over the last few months, a bit similar to with the response I just gave earlier on. And this is at a time when staff are still dealing with the ongoing demands of the actual pandemic, the vaccination rollout, and the onset of winter pressures. A great deal of work is being carried out across Berkshire West surgeries to support them so they can be confident that they are all positive for results for the next Mori survey, as you said, in January 2022. As for South Reading surgery, key areas of work include, and I'm going to give you, Mr. Brown, a list if this is okay. So the CCG clinical lead and the primary care manager holds 6 weekly contract review meetings with the practice, and these are focused on patient experience. The practice has a patient experience action plan in place. These include practice conducting their own in-house survey. Each team within the practice has been asked to review the in-house survey and identify improvement actions they can take. For example, the reception team have put their own improvement plans in place. The action plan detailed 17 questions, including one about the overall experience of the practice, and 65% of people who had responded rated the practice as good. The CCG will also be discussing ways to improve further at its next contract review meeting, including ways of reviewing results with the patient participation group. Thank you.
Thank you, Katie. Francis, do you have a supplementary to that?
I was wondering how many patients did actually answer that questionnaire, and to make the observation that actually for most surgeries, the result good or very good is usually much higher than 65%. I was also invited to join their PPG on 3 occasions in previous years, and I would say that they're rather isolated. They had never heard of the Health and Wellbeing Board. They'd never heard of the Clinical Commissioning Group or South Reading Patient Voice or Health Watch. And I would wonder if you would consider, Katie, involving other people with perhaps more experience of these matters to assist the patient participation group there.
Okay, thank you.
Isolated.
Sorry, thanks.
Thanks, Francis. So to be quite honest, the first question that you asked about the number of people that were actually part of that survey, I have to go back to the actual practice and the primary care team to get your response to that. So I will actually ensure that that is sent to Nikki and yourself to give you a response on that. So I'm sorry I can't provide that to you at the moment. On your point about the PPG and their involvement and needing help with understanding about the roles of certain statutory organisations, I'm happy that actually I will work with the PPG or get somebody from the primary care team to actually link in with the PPG and give them some explanations. Obviously, I'd be keen for actually ensuring people such as Mendeep join me with giving understanding about how Health Watch and the role of Health Watch going forward, so they could be actively involved with as well. So I will do that and action that going forward for their next PPG meeting.
Thank you so much.
Great, thank you. Thank you for the questions and the answers, Katie. Right, I don't think we have any petitions, do we? No, Nikki, I'm sure we don't. In which case, we move on to item 5, which is the COVID-19 impact update. So is Becky Pollard going to lead off on this?
Thank you, Chair. And to introduce myself, I'm the new interim public health consultant for Reading Borough Council, joined on the 20th of September, so delighted to be part of the public health response in the borough. So I think I'm going to give a quick update. You have regular updates on the situation of COVID.
Sorry, Chair. Sorry, Becky. Chair, did you see the email I sent you about the hospital item? You obviously haven't seen the email.
No, sorry.
Sorry, I should have mentioned it at the beginning.
Is that request to?
Yes. Sorry, I don't know how to pronounce your name. Ragiv
Sorry,
Basin?
yeah. Hi, my name's Raghav. I'm accompanying Ali at the hospital lighting, and unfortunately I need to go by 3 today. So I think Nikki kindly requested if we could jump up the agenda.
So
apologies, Becky, for coming in.
I have
very last minute.
Sorry, I'd sent an email, but I
so I've been a bit busy. I've been looking after sick people in my house today. It's been a struggle to get to see stuff.
Yes, we were expecting just Ali.
Becky's okay with that. Everyone's okay. Let's move that around because clearly we don't want to be missing a key part of the presentation. So that's the hospital.
Yeah, sorry about that, Becky.
Yeah. Okay, right. Let's all jump to item number 7 then. We've got Alison Foster, Programme Director at the RBH Trust. Alison, you're on, suddenly much quicker than expected.
Yes. Hi, thanks for that. I did send through a presentation, but can I share my screen and
yeah, I can do that if you want. I just I have the other ones primed up, but I can get yours primed up, or you can share your screen, whichever you prefer.
Yeah, I can. If I share mine, then I know when to move it along.
Yeah, no, that's fine.
Okay, let's give that a go. Can everybody see that?
Yeah, thanks, Ali.
Okay, great.
Yes, thanks.
Okay, I'll just get it onto presentation. Okay, so yeah, I've just got a few slides to take people through the Building Berkshire Together programme, which is what we've called the programme for the hospital redevelopment programme. I started in this role just towards the end of July, and so I'm hopefully we can give you a bit of an update as to quite a lot of things that have been happening so far. Just a bit of context, no surprises to you all that the main RBH site has a number of issues which include ageing estate, which is extremely expensive to maintain. An exercise was done last year to look at how much it would cost just to fix the backlog, and it came to almost 200 million just to keep on top of all the things that need fixing. There are constant changing needs for clinical space, and in what we are in a confined area, so it's really difficult to flex space when we need to flex space, and for example in times of COVID or other areas such as helping to move waiting lists and increase capacity in terms of some of the elective care. There's some transport and travel issues related to the site, and there's a desire to achieve net zero carbon. Along with the NHS, we are completing a plan to achieve net zero carbon, and we are submitting that to our board in December. So a bit of context. So in September 2019, we were announced as being part of the new hospital programme, the 40 hospitals, it's now 48, but the 40 hospitals, and we were given funding to develop the business case for the redevelopment. We submitted our strategic outline case. That's part of the business case process, is the first stage, and I'll come to the areas which were highlighted as preferred to take forward to the next stage in the next couple of slides. So during 2021, we've carried out a number of what I'm calling enabling work. So there's been some demolition of key buildings, getting ready for some development. There's been a big de-steaming exercise. There's a space utilisation exercise. There's a review of clinical strategy. So post-COVID, we obviously have a lot of lessons to learn around a number of things about how we do things. So how we use digital for virtual appointments, or how we move things that were traditionally on the site, thinking about maybe moving them off the site. So we've utilised spaces in Townlands and in Bracknell, for example, and in West Berkshire. There's developments across the integrated care system around how we work with our neighbouring trusts that we need to take into account. We need to plan for net zero carbon. We've got a parking review happening at the moment. I know it's a contentious issue for many visitors and who come to and patients who come to the site. We are doing a lot of work around that at the moment. And recruitment of the programme team. So as I said, I was recruited towards the end of July, and I now have to and am starting the process of recruiting the team that's required to go to the next stage of the business case process. We've made an application for funding for that next stage of the business case process, and we are also starting off in trying to embed a co-production model in everything that we do. So I've met with the patient leaders in the hospital to start some of that work, and I'll come back to how people can feed into that in later on in the presentation. So the next stage is the production of the outline business case stage. And I just have a slide here about the business case process. So for those who aren't aware, to access or secure money from the Treasury, there is kind of a three-stage process. which is the strategic case, the outline business case, and the full business case. And what goes on in each of those stages are just highlighted there. So we're just about to start stage 2, which is the outline business case, which goes into a significant amount of detail around the options that we have decided to take forward from the strategic outline case. So in terms of the options that we took forward, one of the options was development of an emergency care block, an elective centre for planned hospital care, a new women's and children's facility, and a potential for a medical school. So that is to redevelop on site. A further option was building of a substantially new hospital on the current site, and it lists where those buildings will be on that. And then the third option was a full relocation and rebuilding of a new hospital in a off-site, so out of Reading. And a couple of those options being explored, many people will be aware, are areas such as Green Park and the Shinfield site, Thames Valley Business Park. So those were explored as part of that initial stage. But it's important to recognise that we are part of the government new hospital programme. So we are, what does that mean? We are phase 4, what are called full adopters, and scheduled to start construction 2025-26. We should benefit from the learning from earlier phases. So in the earlier fit, there are people who are in construction now, people who are ready to start construction, and benefiting from things like standardized design, modern methods of construction, looking at how we can reduce costs, not do things once, or not do things multiple times that we could do once and share. So if I sort of describe it as everybody's building on these 40 sites where we're looking to build a hospital, but there are standards that we all have to meet. So we're looking at what can a standard design look like. So if we did that and we did that well, we would save a lot of time and money in designers, for example, in design costs, if we were to bring some of that more centrally. So there's a lot of work being done by the national programme team to try and standardise where we can and to bring things in more centrally. So we're in the 4th phase for that. So the key priorities at the moment, certainly for me and the team here, are to establish the programme. So there is a huge amount of work involved in the next stage of the business case. We have to establish a long list of options based on key success criteria and investment objectives that we have to review. We have to then go from a long list to a short list, and then select the options. Alongside that, we are looking at our clinical model. So the clinical services strategy has been updated. So we need to look at how that changes into a working model. There are huge advances even in the last year in terms of digital and workforce. So there's a huge amount of work that has to be done in the next phase, which will involve a team of people to do that, and also some external support to help us. So design support, surveys to do that, healthcare planners to help to do some of that work. So that's the first area, and then progressing the priority areas in work streams that I've listed there. So there are 5 main work streams. So the clinical model, for example, what we're starting to do now is, after the clinical strategy has been reviewed, we're now looking at phasing the next stage of that. So where we think we want to implement changes for children, young people, then there will be a tranche of work that will involve the community and partners around what does making this operational look like, what does changing this work stream look like, so that we can make things better for patients in our population. So huge amount of work that's got to be done for the clinical model, and that's got to be ready before we even think about design. So what do we want to deliver for our patients? Where do we want to deliver it? And then we work with designers to then start to shape that, and all the way through we'll be working with the patients that we've got here, patient leaders, and the public who want to be involved in that. And I'll come to how you get involved a bit later on. So those are the kind of main areas of work streams that we're just embarking on now. So some further information on the Building Berkshire Together website. So we've got a website there that just gives some pointers as to events as they come up, how you can get more involved, join the network. So what we've designed is where people sign up to join the network, you can say, I'm interested in this area, I'm interested in children or orthopedics or cancer services. You can say, would you like to be involved in a working group or just a one-off session? You know, what are good times for you, so that we can start to think about, you know, if we've got 10 people who say the only time who are interested in looking at the cancer pathway, but they can only do a weekend, then we need to shape something around doing something at a weekend. So we're trying to build that network of people who want to help and contribute, but also who want to just be kept informed, so that we've got direct contact details. So as we produce regular updates or need information to go out, that we've got a contact database of interested people who want to know more of about that, to add to the regular forums where we might have that opportunity, such as this forum, such as Health Watch, who we've been in touch with to come and talk to us and get a briefing about what we're doing. And we're also, there's a workshop next week on the net zero carbon that I know that somebody from the council is going to be speaking at in Reading Can. So we're trying to look at, you know, how in the any sort of new build that we do, and either on site or off site, that we build that connection in. Sorry, is somebody trying to talk? No? No, okay. So I think that's it for the update, but I'm happy to take questions.
Oh, so great, thank you, Alison. I've got a few questions, but I'm going to open it up. Questions, people aren't indicating. Maybe I will start. There must be questions. I've got a few. Any questions or any points people want to make? Okay. Oh, in which, Ramona, did you looking to ask? I have got somebody indicate. Ramona Bridgman.
Hello, I'm Ramona Bridgman. I chair the Reading Families Forum. Hi, Alison.
Hi.
I've spoken to your predecessor about it, maybe before COVID, I think, probably. But there's nothing in your presentation about accessibility, and I know a lot of disabled people, particularly families of disabled children, find that the hospital really inaccessible. It's really difficult to get into paediatric A&E if you've got wheelchair plus equipment. It's really difficult to find your way around. It's difficult to get a mobile hoist that's charged up, because there's not enough hoists around in the hospital, all those kinds of things. It's actually quite difficult if you've got a child in a wheelchair or you're an adult in a wheelchair to get from one part of the building to another. You haven't mentioned it in your presentation, but have you got it in mind when you're doing the bids that we really need to get this sorted, please?
Yeah, so yes, in short, so the space utilisation, space planning work, and the work involved to so for example, if we got the go ahead tomorrow for funding to build a new hospital, we know that if it was a new hospital offsite, it's probably going to take the best part of, you know, 4 or 5 years minimum, probably a lot longer. So we can't wait that long to make improvements to what we've already got. So we do have work that we're sort of progressing to look at key areas where we need to make improvements within the budgets that we can. So we're reviewing things like health and safety issues. We're reviewing things like accessibility is part of that criteria in terms of space and access. So we've got, you know, there isn't enough time in the presentation to see the whole list of things, you know, and there's a whole list of things that is contributing to our business case as to why we need the redevelopment. You know, we've got huge space restrictions on here, so accessibility is one of those things that I'm actually progressing to our estates committee in December, a series of proposals around what are the things that we need to progress while we're thinking about a wider scale redevelopment, and what can we do with the envelope that we've got. So yeah, thank you just for that. It's definitely on the agenda.
Thank you, Alison.
Okay.
Great, thanks Ramona for that that important question. So I've got Jason Brock, and then I've got Katie Summers after that. Jason.
Thank you, Chair. Thank you for the presentation. Very interesting, and clearly it's a really important project that has ramifications for residents right across Reading, and rightly they'll be incredibly interested with it. And it's really pleasing to see the way in which you're seeking to engage the public. And I've just gone on to the website, which is actually very useful and maps it out all very neatly. If possible, I missed this. So just a quick question, and then, Chair, if I may, a further point thereafter. What is the sort of timeline for the submission of an outline business?
Okay.
Strategic outline business.
So generally, it takes anywhere between 12 and 18 months to do an outline business case. We are waiting we should hear this month about how much funding we've got to progress that work, and depending on that funding, we then match the resources and then say, right, this is how long we think it's going to take us with this amount of funding. So it's usually between 12 and 18 months for an outline business case.
And the outline business case, sorry, I now have a second question, Chair. You see, things get more complicated as I go along. The outline business case will focus on a single preferred option.
No.
No, so it will also take this plethora that have been incorporated into the strategic outline business case, right? Yeah.
So the stage is quite sort of high level. Is we will review our investment objectives based on our current context, so that our spending objectives, and then based on that, there'll be critical success factors to link to that, and we have to establish a long list of options, and we do that with staff, community, a whole raft of stakeholders to say, okay, this long list would meet this criteria, and then we have a process, an options appraisal process, to get that down to a short list, and then to get to a preferred option. So it's to help us get to a preferred option. So we will get to a preferred option at the end of the outline business case based on the work that we've done exploring a range of other options.
Thank you very much, and I'm sure we'll all follow it very intently as it progresses. Chair, in view of the sort of importance of engaging with this as we go along, I just think it would be wise if the ACE committee, which is our statutory overview and scrutiny committee, had as a sort of standard agenda setting item a request to the trust to see if there are any updates that they want to bring along to whatever the next meeting of ACE is, which is 3 or 4 times a year, because I think that's the best way to ensure that the council remains across from things as soon as possible and has that opportunity to provide input and scrutiny in a sort of formal setting. Doubtless, there's input and scrutiny in informal settings as well, and this meeting is a great opportunity, I think, for the trust to be able to reach out and speak to lots of different partners, but it's not a good opportunity really for us to do what we would see as our sort of constructive engagement work. So I just wanted to put that to you, Chair, and ask you to take that away, and I don't think the Chair of ACE is on the meeting today, so if I leave that with you.
No, thank you, Jason. The hospital came to the last meeting base, it's not come to the next one, but certainly, whilst I can't speak for the chair, as a mere member of that committee, I think that's something that in fact, we all said was something that we wanted to see as it all progressed. So, completely agree with that. Was there anything else? Anybody else indicating? Because I kind of following on from Jason's points. So hopefully, Alison and the hospital said before that they wanted to engage with ACE as this progresses as well. In terms of that, I've got a couple of questions. So the first and the main one is I still am slightly confused. Well, not confused, but I don't understand the decision-making process to get to the preferred option, because presumably, as they cost different amount of money, is the Treasury or somebody involved in what you're allowed to do? So who actually decides in terms of? And clearly, I think all of us want to see, the most, a substantial redevelopment, new build. the contention is whether it's on site or off site. And so, yeah, who kind of makes that decision? You give an idea of the iteration process, but presumably it's not within the gift simply of the trust in terms of which you can do, because you have to ask for the money. So that's my first question. And the second one is, you talked about co-production, that's great. And I suppose just in terms of that, as that develops, I think the support of the voluntary community sector in this town and the council and everyone, in terms of ensuring that some of those, like, you know, I find it an ugly phrase, but those seldom heard voices, those that often are least likely to be heard within those consultations and co-productions, are involved in that. I think that's really important. And my other question then is, the net zero carbon is fantastic. I know you've got a workshop coming up. One of my questions is the transport to and from both staff and visitors and patients to the hospital, is that included in your considerations? Because whilst it might be difficult to deliver zero carbon on that, but clearly that will be a carbon impact of the hospital, and I've no idea which ones, so my question is that involved as well in terms of the workings around the carbon impact of your proposals? Thank you.
Okay, so I'll take that last one first, which the scope includes staff travel, but not patients travel to and from. So at the moment, that's out of scope. So the first, and if you need me to send stuff on that, I can do that, but that's currently the guidance. The first question about how the decisions are made, absolutely. It's at the end of the day down to the Treasury. The way that we present our case, however, is we will look at what are the needs of the population, not just now, but for the next 10, 20, 30 odd years potentially. We work with the local ICS and public health and say, right, this is, and then we look at all our data on demand and capacity, and we say, right, this is what we predict we're going to need, and it's well tested, and then we're going to put proposals that hopefully come as low cost as possible, so a good value for money option, and they're assessed. There's a criteria that assesses whether something's good value for money, and all of those go into the business case and are properly assessed using a comprehensive assessment, impact assessment. So, for example, if we propose one option in the strategic case was to just fix what we've got, it's not sustainable. It's not what we would consider the best option for the population, and for the best options for the population we chose as going forward for the OBC, but into the next stage. But it's still within the gift of the Treasury to say we only have 200 million, and that's all we can give you. So that's we'll have to cross that bridge if we have to cross that bridge when we come to it. But we're going to make a case for what's the best needs for this population, and then we have to ask the Treasury for that. They decide, but we pull the information together to help that decision.
Thank you. I think that's really useful and kind of what I thought was the situation. So I suppose there's also, as well as this body with ACE and the council and various different groups enabling the that co-production, that conversation, so we're all working together on this. I suppose there will come a point where lobbying of MPs and councils in terms of the importance of the development might be something that we all need to lay into in terms of supporting the bid, I guess, in terms of ensuring we get the maximum amount of
resource. Yeah, and I'll be honest. At the moment, the net zero carbon target, we are really going to struggle with if we have to build on site. So we are looking to any help our local MPs can give us to help us work our way through some of those sort of dilemmas that we've got ahead of us.
Okay, thank you. Yeah, and I'm sure all the local councils around very much. I know all of them, agree how important this project is for the area. Okay, thanks. I haven't got anybody else indicating, in which case, thank you very much. for coming. So yeah, you've heard. So I think that's absolutely right. So as Jason suggested, regular reports to ACE, I think would be a good mechanism for the council and councils being involved in this. So unless anybody else is indicating which not, I'll say thank you very much. I was slightly surprised because Boris Johnson did declare that he'd already built 48 new hospitals, which I assumed was. Well, I kind of guess that couldn't be right, as I remember one being developed here. So thank you very much for coming in.
Oh, you're welcome.
See you again in the future.
Okay,
Thanks.
thank you. All right.
Bye.
Bye.
Okay, everyone. Right. So that was. Let's go back to where we were a moment before. Item 5, which is the COVID-19, and Becky Pollard, déjà vu, back again. So.
Déjà vu. I'm still here. Yeah, I don't know, Claire, whether you want to load the slides. People have seen them. They were in the pack. Chair, I can just go through. Right, brilliant. Thank you, Claire. So yes, I've just got a couple of slides, and what I'll do is just pick out the key points in each of these, and then I think Katie Summers and Deborah Glassbrook are going to just add a little bit from their perspectives of where we're at. So the first slide looks, I think you'll be familiar with this dashboard now, which compares where we are in Reading to our sort of nearest neighbours. And the key point here really is that we remain slightly higher than most of our neighbours across Berkshire, but thankfully we are still lower than the England average. Our testing rates are higher, which is good news, and our positivity rates are slightly lower, which again is good news. But we're monitoring this all the time. So if we move on to the second slide, this looks at what's been happening over the past year, and you'll all be aware of the peak last winter and then dropped down significantly, and then we've seen an increase since the summer, but it is plateauing, which is good news. It's bumping around. So our case rates at the moment are about 300 per 100,000 people for all ages, and for older people 109. So clearly we want to just keep an eye on what's going on, particularly as we go into winter. So the next slide looks at the age breakdown. So this is a heat map. So the darker shades are the higher rates. So you can see at the moment the highest case rates are in the 5 to 16-year-olds, and I think we're all aware, you know, of that at the moment. But it does look like it has slightly dropped in the 5 to 10-year-old age group, but we'll, as I say, we're closely monitoring this. And if we go on to the next slide, you'll see that's just another presentation of where the positive cases are in terms of the 11 to 16-year-olds. So obviously a lot of work going on with schools and the community about, you know, how we address that. If we go on to the next slide, this looks at the geographic incidence of cases. And actually the picture's changed here. At the start of the pandemic, the case rates were higher in the centre of the borough, but now more recently we've seen that spread out to the Southcott, Kentwood and Thames and Maple Durham wards. Now this does fluctuate, and we're not quite sure why this is the case. It's not just within Reading. It's changed across the country. It might be something to do with immunity levels, but that's the picture as it is at the moment. If we go on to the next slide, this looks at mortality, death rates. So again, sort of remained, we saw the peak last winter and then again in the summer, but thankfully, if you look right to the right, the death rates, the mortality rates have dropped, and the COVID deaths have dropped significantly. But as we get into winter and with the influenza season, we just again need to watch that, and clearly that has an impact on pressures within the NHS. But at the moment, it looks okay and good picture. The next slide looks at case rates in schools, and again that just echoes what I've said before. We saw a huge rise coinciding with start of school, maybe also impacted with testing, increased testing, so we're finding more cases, but it has dropped, and that seems to be the picture across the country. So again, but we know we have got outbreaks and cases within individual schools, so we just need to keep watching and reacting to the data as it comes. The next slide looks at the pressures on the hospital. Again, it's a reasonable picture. It's dropped significantly since the peak last year. Currently, I know it says 40 here, people in Reading hospital. Latest data on the 4th of October, that was down to 34. But again, we have to continue to monitor that as we go into the autumn-winter period. The next two slides are just about the vaccine uptake. So this one looks overall at our uptakes of the vaccine first dose, second dose in Reading. We are and have been consistently under the national and local, well, regional level, but we have remained consistent in that. And I know, having just joined, I think there's quite a lot of discussion going on about the denominator that we use for our uptake rates and whether that's impacting. But I think the point I want to make is that it hasn't changed, so it's consistent. So we still got more work to do and to unpick that. And then the final slide is really looking at the rates of one dose across the age groups. So overall, those aged 16 above have had 71%, just under 71%, have had at least one dose, and nearly 65% both doses. And in our older age group, very vulnerable group, 90%. So the only other points I'd make before I hand over to Katie is we do know there's variation in uptake rates across the wards between different ethnic groups. We're doing a lot of work around that. We know we've got a particular issue with the Chinese community. Their uptake rates are very low, and with mixed Black and Caribbean groups. So we're doing a lot of community work engagement to try and explore that, to see what we can do to encourage uptake. But I'll hand over to Katie now, if that's all right, just to continue more about the vaccinations.
Yeah, of course, thanks.
Okay, Nikki, could you put the slides up if possible? My screen's blank, is that right? Or oh, thank you very much, Nikki. So maybe put it on full screen if possible. So just to complement what Becky was going on about, so generally, obviously at the moment, we've still got 29% of the Reading population who are still left to be vaccinated. However, as Nikki was saying, obviously there are some conversations going on about, do we truly understand, is that the true denominator? Because we've got a very transient population in Reading as such. So there's a huge amount of work that's going on here. I don't know if you can see this slide, but this just generally gives you an update about the timeline that we have all been working to as part of the COVID vaccination. And obviously I feel that it's worth sharing this to recognise that actually we've gone through a significant amount of progress over literally a year's time. So obviously in relation to that is that we started the actual vaccination programme back in December. And that's when we only had one actual vaccine that was actually generally approved. But then quite rapidly, we then adopted more sites that would be available to deliver the vaccination programme. And also we went live with the Majesty Stadium as well, which was back in end of February, beginning of March. So we have been doing a huge amount of work in order to do that going forward. Now we're in a stage where we're moving into work of an evergreen offer. So for those 29% of the people who are still left to be vaccinated, they can still be vaccinated. There are still opportunities for anybody to come forward and take up this opportunity, but we're also targeting the work of the young people now, as well as supporting those people who require a booster. If you go to the next slide. So this is sort of a summary about where we were at the moment. So you can see here now we're in this phase 3 booster programme. The phase 3 booster programme is at the moment, I don't think this slide really gives it justice, but just to give it in a very simplistic terms, if you are 182 days post your second vaccination, then you will be contacted in order to come forward for a booster. So at the moment, the way this is rolled out is, if you go back to the very beginning when we went through the cohorts, the first cohorts was very much that over 80s, the care home people and those most clinically vulnerable. So in total for Reading, that accounts for 4,364 people at the moment. But each week that number will change because that 182s will flex because we'll go through different cohorts. So at the moment, we're really targeting those people who are 182 days post. That's both from the point of residents as well as staff. We're going in now to supporting residents who are housebound, as well as those people that are registered into a care home or a learning disability centre, and actually organising opportunities for going in and actually vaccinating those individuals. We've also got a number of sites that are actually doing vaccination programmes, and if you go to the next slide, I'll come on to that. So we are going forward with now different locations. So for now, we've got a number of GP practices that have now been delivering the actual vaccination programme. So originally in the first phase back in December, we had actually offered it out to all Reading PCNs, but obviously in phase 2, which was at the beginning of the summer, some of those practices needed some time to just recover and plan out, so we only had one site that was actually continuing. Now we're into phase 3 with the booster. All practices have agreed that they would deliver on the booster programme as it is at the moment. We've also expanded the number of pharmacies. So the number of pharmacies traditionally were Tilehurst, Western Elms, Ely Road and also Boots in Reading, but now we've gone forward with more people, which is Tilehurst, Ely Road, Boots, Reading, Mortimer and New Days, which is in Wensley Road. So we've got some more sites that people can come into. We'd also continue with the offer of the actual Broad Street Mall, which obviously has now replaced the actual Majesty Stadium. So we've got lots more opportunities for people to come forward and actually have their vaccination. That vaccination is not only for the people with boosters, but also the evergreen offer, whereby you've got that 29%. We are still offering it to those 29% within those areas. So it's a really good offer going forward. If you go to the next slide. So this is a bit of a summary about where we are at the moment. I don't think there's anything that you've just seen this slide really going forward, so you can see what the uptake is. For the phase 2 for 16 to 17-year-olds, a bit of an update on that is the numbers here for the first vaccination. This slide is actually from 26 September. I can just give you the latest figure for 16 to 17-year-olds. 52.5% of the population have been vaccinated who are 16 to 17-year-olds. So we're slowly progressing on those 16 to 17-year-olds, but that's still a case for the fact that we are trying to actually encourage everybody to come forward. If you go to the next slide. The other offer that we're doing here is on the actual flu. So obviously for the flu programme, the key messages here is the fact that we are encouraging all primary school children, as well as those children who are in that nursery phase, to come forward and actually have their flu immunisation vaccination. We're also encouraging those people that are pregnant, 50+, those in long-term residential care, carers, immunocompromised, and also frontline health and social care workers to actually come and be vaccinated. Just to make people aware, we have now got guidance from the JVCI to say that we can do co-administration of both flu and also COVID vaccination. So many sites are doing this now where they can do both, as long as they've got the availability of both the flu and also the COVID vaccination. I do know now a number of the pharmacy sites are actually doing that co-administration, and it's working incredibly well. I'm not aware of any issues or any clinical incidences regarding that information. I think that's a very strong message that we need to be providing going forward. If you go to the next slide. This is a bit of comparison about the national uptakes. So you can see here a bit about the uptakes that are going forward, and this is the information about the Reading. You can't really see much here about what's going on, but just to sort of say, if I focus on the 12 to 15-year-olds, the 12 to 15-year-olds, obviously the schools, Berkshire Healthcare Trust school immunisation team are actively going into the schools at the moment. They're doing a huge amount of work to encourage those children to come up and be vaccinated. They have done a fantastic piece of work with consent. They're working very closely with all the schools. They're sending out information over a week ago before they actually go into that site to get permission for the consent. So it's consenting with the actual parent, I would actually say, that's going forward here. They close that consent period within 48 hours, and then obviously the children, they have the actual vaccination delivered on the actual site of the actual school. The aspiration is they do feel that they're going to be able to complete all schools by the 8th of November. However, the one thing I would actually say is the fact that there are some parents who don't necessarily sign up that consent form within that actual period when they notify them about the actual issue. So what's being talked about actively here is about a mop-up service at the moment about how do we support those parents who haven't necessarily signed the consent form but are wanting their children to be actually vaccinated going forward. If you just go through to the next slide. So this is a bit of a forward plan about the actual immunisation programme and the flu programme, just to make people aware about this. So it's just really for information. Obviously, we are hoping that 12 to 15-year-olds, we hope that they'll be completed by October, but we just got confirmation that they will be completed by the 8th of November. We're doing the booster programme, and that's obviously within general practice, and that's within the PCN sites, as well as some of those community pharmacy sites. We're actively working with the mass vaccination sites to vaccinate those frontline health and social care workers. For anybody who's a social care worker, what we're doing here is encouraging those people to either be in their place of work, so if they're in their care home, obviously those people will be vaccinated by the individual PCNs themselves, or people may choose to actually book on via the national booking scheme and actually be booked into a community pharmacy site or into the mass vaccination site. And I was giving you an update about the flus. For the flus, I would actually say here the school children obviously were hoped to be actually going to be vaccinated by autumn. For primary school children, it's hoped that they will be actually vaccinated by the end of the year, going as it is at the moment. So I hope that was a bit of a whistle-stop tour for you.
happy to wait for questions, Chair.
Great, thanks. Oh, sorry, they're coming away. Is it worth taking, because there's quite a lot in there, wasn't there, in terms of any points and questions on the first two before coming to the rest? Jason's indicated, so if Jason Brock, do you want to come in now? Ramona Bridgman, I'm just thinking, because whilst a lot of that vaccination and the rates is on our mind, it might be an idea.
Sure, okay.
Okay, right, so I've got Jason Brock indicated first.
So you're bringing me, okay, thank you, Chair. I mean, it's just to say, well, a few things really. Firstly, the data is obviously very useful, and it's become a bit more sophisticated over the course of the last 18 months and so on. But we've kind of reached the point now, I feel, where there's a sort of maturity in the data collection, and we're trying to make policy as a result of it. But it's where the sort of noise in the data and the issues with the data start to become more and more important. So, for example, it's wonderful to see that Reading has a far higher testing rate per 100,000 than any of our sort of neighbouring authorities, far higher than the South East average, far higher than the England average. But we also know that our population tends to be underreported. And so, in fact, if we were to adjust it for what probably the true population is, our testing rate would be slightly lower per 100,000. And our sort of case rate would likely be slightly lower per 100,000 as well. And I've spent the part of this afternoon going through the data as produced by NHS Test and Trace. And it's been quite interesting to read through, but I couldn't actually find what the source of the population is. So I assume they're using the census, but maybe they're using something else. Similarly, with the vaccinations, and this was touched on by both the presenters, we've had teams at the council who have been going out and knocking on doors of people who haven't had a vaccination. And what those teams are finding is that roughly 50% of the doors they knock on, the people they're after, don't live there anymore. So, 50%. So the patient lists held by GP surgeries clearly have an issue. I don't know whether that issue is greater in Reading than it is elsewhere, but it certainly feels like it is, which would explain something of the disparity between our vaccination rate expressed as a percentage relative to the regional and national average. Also, the fact that Reading has an unusually young population continues to play an element in that, of course, but the issues with data are doubtless part of it. And so I suppose I kind of find myself wondering why we now, the other point sort of related a bit to that, is that with testing levels being so different across the different areas. So I looked, the number of tests in Reading between the end of May and the end of September were 245,467, whereas in West Berkshire it was 179,339, which I think is a 37% difference between the two. So surely we can adjust our kind of, case numbers for what we estimate the true case numbers to be, because we're dealing only ever with actually confirmed cases. But it would be much more helpful, I think, for local authorities to have at least some sense, all right, expressed with a confidence interval and so on and so forth, to have some sense of what the estimated true number of cases is, adjusted for the fact that testing rates are quite different in different areas.
Okay, thanks. Quite a bit there, a bit for Beck and a bit for Katie.
Yeah, so I'll kick off first. It's certainly something that I've become aware of since I've started working, and I've raised it, and I think Meriden, I don't know if she's on the call, but and some work has been done to unpick which denominator is being used, because if it's for immunisations, they have a different database system, NIMS it's called, and as you quite rightly say, ONS census estimates for some of the other rates. So I think we do need to unpick a bit more, and as you see, maybe sense check and just check what the data we're seeing, you know, where there could be variability. But Meriden, I don't know if you want to comment more on that, because your team's been looking at some of this.
Yeah, sure. I mean, there are 3 different types of getting data for vaccination. One is using ONS data, percentage of ONS population, or you can use the ONS estimates. Sorry, census is the first one, which we know is out of date. And then there's the ONS estimate, or there's GP practice registration. And if you use GP registration, what you often find is your population is 105 or 110%. And that's because, as Councillor has rightly said, as the leader has rightly said, people move in and out, and the list sample was accurate. But also some people live outside the area and register with a practice, which is quite feasible. Now, when we get our local data, which is the best data for us, it is based on the GP registered, and we use the GP data to give us the vaccination rates and for cases and things. So that doesn't always match the national data and the NIM system. So for us to get really good local data, I mean, Katie and her team have been really helpful in using GP data, because that gives us a much better picture of inequalities. So that's why there's some slight discrepancies. And you know, it's down to GPs. Once we identify people don't live there, it's down to GPs then to sort of change their list. So, and you know, they have to run their own practices.
So just to complement what Becky and Meriden have said, from the NHS perspective, what we get information on the uptakes of the vaccination is directly generated from the GP practices. We have identified ourselves, a bit like yourself, Councillor, that actually there is an unclear denominator based on that for the actual Reading practices. I was the one who kicked off the actual list cleansing, so it's really good to hear that actually you heard yourself that actually 50% is actually a key issue. The one thing that we're working for at the moment is that the GP practices need to do a list cleansing exercise. So at the moment, the CCG is going to be working up a plan to do that list cleansing exercise across the whole of our Reading, Wokingham and also West Berkshire exercise, but prioritising Reading. So we're going to kick off that piece of work to do some list cleansing. It hasn't been around, we haven't done that for a number of years, but it feels as if now is the right time to do it. That will actually give us a much better understanding about that clear denominator going forward as such. So I agree with you, the fact that actually the confirmation of the data sources is a key thing. The one thing I am doing, and I've literally just kicked off, and I haven't spoken to Meriden about this because it's just literally happened, but what I'm doing is I'm actually getting from the GP systems, my analytics teams, to look at the number of COVID identified cases and against those people that have been vaccinated, because actually that would be a better way for us to identify also the number of COVID cases that are linked into the GP systems going forward. I think that would be a really helpful report. Just literally kicked that off literally 2 hours ago. So I think actually what we could do is bring that back to a future meeting to give you a better understanding. And obviously I think this is a report that go through to Meriden's Health Protection Board as well, because that's a way that we could have one version of the truth going forward. Does that help you at all, Councillor?
No, it does, and you know, I'm really grateful, and I suppose it just shows the importance of having good data sets. And I completely understand why a sort of list cleansing exercise is not convenient to undertake in the midst of a pandemic, and it takes a lot of administrative effort, so on and so forth. But it shows the importance of scheduling that on, I think, a regular basis, because you can't see these problems. But it is, I mean, it affects, I suppose, any time that we're trying to set policy around health or around social care and so on, you know, knowing that the data has a good integrity.
Yeah, I would actually say, just to compliment you, obviously, because you are a university unitary authority, I have been having conversations with Oxfordshire. Oxfordshire have exactly the same scenario, because it's a very very transient, ethnically diverse population as well, and they're having the exact same issue. So with list cleansing from a point of view of with the GP practices is a really key thing that we all need to be actually doing.
Okay, thank you. Thanks, Jason, for that. It's obviously really important. I will have to say, GP list problems was raised sort of 10, 12 years ago, but I think there wasn't very much incentive of the GP practices to strip out patients in the olden days. So it's obviously really important in terms of when we come to issues, particularly around vaccination rates. And I'll also just lob in. I'll bring on other people. Of course, we also are unclear at the moment how many EU citizens have left Reading and have yet to come back. It's really difficult in terms of, we know there's quite significant and major changes in the population of the country. Actually how we work out what's going on in Reading is obviously really quite difficult, but incredibly important. Right, I've got Ramona Bridgman and then Mandeep Baines. Ramona.
Thank you. It's a really helpful presentation, everybody. Thank you. It's just a request for a bit more information for disabled adults and families of disabled children and young adults. One of the examples was the 12 to 15 clinically extremely vulnerable. Those who weren't at special school, it was really confusing how they would get their children to have their first COVID jab. And we had to do a lot of work with your colleagues and with the CCG to find out for families how that was going to work. And I noticed on your PowerPoint, Becky, it was saying about people who are immune suppressed having their third jab over the summer. Well, I'm immune suppressed. I've been clinically extremely vulnerable. That I haven't been made aware of that at all.
Can I come in for that? I could give the answers for both of those, if that's right, Becky. So yeah, apologies for that, for the lack of clarity for 12 to 15 who are extremely clinically vulnerable. I do know that actually the PCNs have been encouraged to actually do those actual individual, I don't want to call them patients because they're not patients, children as such, to come in and be actually offered. I will get hold of the numbers that actually are still required to be vaccinated in Reading. I need to just double check that information, Roma.
I don't think everybody knows how it's going to work, and
so we can work. I can get our comms people to actually work with you, Roma, to provide some clear understanding about how they could actually work towards that. On the issue of the actual immunosuppressed, so there is a letter that is actually, well, should be going out literally next week for anybody who is known to be immunosuppressed. You will be contacted by your actual trust in order to come forward for your actual third vaccination. So anybody who is immunosuppressed, they should be offered a third vaccination, as well as a booster as such. So a letter will be going out from the trust that will be copied into the GP practices, and that should be the trust should be doing that sometime next week or the week after. You will be encouraged to go into the individual trust to get your vaccinations.
Right.
There is a bit of issue. This is an issue across the country at the moment. Right. So
right. Yeah. I just thought from the presentations that I'd missed something.
No.
Thank you very much.
Great, thank you. Mandeep Baines.
Thank you. Actually, Ramona's really helped to make my point, which is I think there's a real need for some updated communications on how the whole vaccination programme is going to work for the third vaccination and the booster, as well as the children's vaccinations. For example, who will contact individuals about their booster vaccination and how will they receive that information and what will their choices be? In terms of the Healthwatch Reading helpline, our number one query still remains people calling us about vaccinations, from simple things like which vaccination is available at which site, what can I get? It seems like we can't do enough communication, and I think it's really important at this stage that all of that is refreshed. So some of even the questions Ramona's asked can be made simply and made available wherever possible to the public, so they are clear about how the system works. They go to the appropriate places. They don't burden telephones with queries if they know exactly where to go and how to make those appointments and what they should be expecting.
Yeah, sure. Thank you very much, Mandeep, on that. So again, there is communication that's available on the websites, but I don't think people are actively looking about this. So we need to be providing clear messages through every different vehicle that we can do. So again, this is a comms issue about how do we get out those messages. But in purest way, everybody will be contacted via the national booking system to come forward to actually be vaccinated. That's route one, and that will be timed on 182 days. Point two, you will be invited by your actual GP practice or your PCN to actually come in and actually be vaccinated, which is obviously also tied into that 182 days. It's quite simple, it's really quite clear and so forth. But one thing I will do is I'll speak with Sally offline here from the CSG comms in order to actually work with Health Watch, work with local authorities to make sure that is a very clear message that we get out. Happy to work with any other media comms to make that really, really quite clear as well, because it's quite simple and I think people are getting mixed up. On the types of vaccines that are actually available as such, obviously that is, to be quite honest, the types of vaccines that are available now, most of the practices at the moment all have Pfizer. However, there is guidance that's come out now to say actually having mixed types of vaccines delivered actually do prove to be more beneficial of having exactly the same booster or exact same vaccine delivered time and time again. But again, that's another comms message that needs to be given. Don't be worried in the fact that you've had AstraZeneca, you might be given Pfizer. It's going to be of benefit for you. So again, it's another comms message that we need to be providing.
Great, thank you. We're about to come to comms, but absolutely, that's really important that we pull together. It was sort of touched upon. One of the things that I've had people come to me about and is around the school. I am a little bit concerned about the school vaccination, and I think there's been national concerns raised, and this is kind of something that's happening across England, I think, in terms of how this is working. But that it's unclear. There's a lot of children where the school environment for a vaccination is not appropriate. They're anxious, much special needs. A lot of kids on the autistic spectrum will not be able to, it won't work for them. And ordinarily through the vaccination programs, there are clinics that are run for those kids to get them. And at the moment, it seems I'm unclear how that's going to work. And it does worry me that this is, in some ways, it might be the kids that we most need to get vaccinated, maybe at the back of the line. I think at the moment, that's not clear how that's going to work. Also, in terms of catch-ups, people that just simply miss the consents and all that kind of stuff. I'm not necessarily expecting you've got the answer, Katie, because I think this is something, as I understand it, discussions happening at sort of a national level. But I think it is a little bit of a well, it's a little bit of a mess, and not your mess, a national mess. And just if only they'd started this in the summer, obviously we'd be in a much better place. But that's just a personal gripe on that. If you do have any information on that, Katie, then please, I'd be interested in it, but I'm not necessarily expecting it.
I won't be able to give you an active conversation, an active response. I would actually say that Meriden and I are actively talking with the schools immunisation teams at the moment to ensure we have a equity to all approach to the flu and COVID vaccination for all school children going forward. I would want to raise that actually I would say that the school immunisation teams are under an immense pressure at the moment. And one thing that we are actively working on is the resources that actually to help them with the expectation of actually providing equity to all going forward. So I can't give you a clear answer here, Councillor, but actually I would want to give you assurance that Meriden and I are actively working on that approach going forward.
Yeah, thank you. I mean, I realise there's consent issues, but we've got huge numbers of doctors that could be able to, in practices and clinics that would be able to physically, do this work, and yet it doesn't appear to be necessarily worked through. But as I say, this isn't a Reading issue, it isn't Berkshire West issue. I do believe it's a national issue in terms of how this is delivered. But thank you. It's good to hear that it's been considered, because I do think that actually, we could be facing a real issue of also almost discrimination against people that are, kids that might have special needs, that perhaps they're going to be at the back of the queue, and come quite a long way at the back of the queue if we're just going to do all the schools before thinking about them. So it's good to hear that.
They are doing the actual special schools. They are.
Yeah, I'm talking about children in mainstream education. That,
yeah. My concern generally is the children that are being homeschooled, and actually how do those children get access? Going into a school environment probably isn't necessarily the best place for them, but actually we're actively working on where we could encourage those people to come in and have a safe area to be vaccinated. Yeah,
that's a really good point as well. Okay, thank you. Right, we sort of we jumped into the middle of the presentation there, but I think it was important to ask those questions whilst the information was fresh in front of us. So we've got Deborah Glassbrook. I think you're going to take it from here.
Yes, I am. Thank you, Councillor Hoskins. So we've probably covered a number of things that I have on my first slide, please, Nikki, which is really an update about schools. And I think we've probably had some of the conversation that I would have been, the issues that I would have been raised. I think Nikki has got my slides somewhere, so I'm hoping they might pop up in a minute. But if I should, I'll just make a start while those are coming. I mean, I think in terms of schools, what we are seeing this term is an increased number of children and young people being identified with COVID. Not too surprisingly, but I think what we're seeing differently this term is the younger children being impacted. So, I've been contacted by one school this week that in the last 10 days had 13 positive identifications of COVID-19 from years 1 right the way through to year 5. I've also got a notification this week from a secondary school that had 28 positive COVID within the school. So I think what we're seeing is a higher number at the lower ends, so children and teachers. And obviously for some of those schools, the real difficulty, if that's going to continue to happen over the winter, of how they're going to manage the teaching, and particularly how they manage in situations where families have got family members who are clinically extremely vulnerable, and the decisions about whether or not they continue to send their children to school where they know that there's a lot of positive cases within that school. So we've been having a number of conversations with that. I've just heard Nikki say about the support the schools have been having from herself and Meriden, and I'd just like to say yes, that's the feedback I'm getting from the schools as well, and they're finding that incredibly helpful. I won't say much about the vaccinations because I think we've just covered that in terms of schools, but what I was also going to say about those children and young people who are disenfranchised from school, as you may recall, we've reported previously that there has been a doubling of those families who have chosen elective home education, and as Katie was saying, very concerned to make sure that we find effective ways of making sure those children who are disenfranchised for whatever reason from school, whether that's electively home educated or just not being able to attend because of their own wellness or their families, or for those children and young people who of course have been additionally affected in terms of their emotional mental health, making sure that we're reaching out for them. The good news is that we've got a second mental health support team coming online. We're just interviewing and recruiting for that at the moment. And you may recall that we are a trailblazer here in Reading for the mental health support teams in the schools. So this second group will go into another set of schools so that we'll have much better coverage across our Reading schools to provide support. And again, what we're hoping to see is a positive impact then on those children and young people who either are currently disenfranchised or who may become disenfranchised from school going forward, and also on how it's impacting for some of our children in relation to their attainment and well-being at school. So we're very pleased to be able to report that that's coming online, and we'll have that broader offer across our schools going forward. I do meet with the head teachers on a fortnightly basis, so do have a really positive opportunity to talk to the schools about the impact of COVID and how they're managing. And for instance, this week Becky Pollard came and talked to them and was able to give them reassurance about what's on offer, again from a public health point of view. So there's an opportunity to provide additional support there. Thank you. If I could have the next slide, please, Nikki, that would be helpful. So in terms of social care, I don't think it will be any surprise for you that we have got an increased demand at the front door. And what I mean by increased demand is really about the complexity of the situations we're still seeing. Reading is no different. We're seeing this across the southeast and beyond in terms of the sort of issues that families are having to deal with and the sort of more embedded difficulties that families are having to deal with because of the additional demands of coping with COVID and the impact that's had in terms of poverty, in terms of family dysfunction and mental health across the piece. So we're exploring all sorts of partnerships to look at how we really deal with those three main areas that we're seeing in terms of poverty, family dysfunction and mental health going forward. The other thing that it's impacted on is our ability to attract foster carers. Again, we've got a reduction in prospective foster carers coming forward. And again, wondering whether or not, you know, the COVID's impacted because people are not wanting to do many things different. We're finding that staff aren't changing jobs in the same way. That's a great news in terms of many ways, but there's not as much movement in the marketplace in terms of work. And again, we're not seeing people coming forward to saying that they would be willing to take children at this time. And we've also had foster carers, of course, understandably now during COVID, who were really quite concerned in terms of their own well-being, of having children from other families and contacts with other families and the impact that could have in terms of heightening their susceptibility to COVID. So we are really noticing that in terms of the local placements. And then the other thing just to say is that although perhaps not directly due to COVID, we have got an increase of unaccompanied asylum seeking young people coming forward as a result of having the hotels here, of course. And just again, thinking about what we were already saying about making sure that those young people are getting vaccinated, that we're able to provide for them, also getting them into our schools, also making sure that we're providing the support for those is just another level of complexity during the times of managing COVID as well. Thank you, Nikki. And then the sort of my final slide really is around our early help and prevention and what we're seeing in this space. And we know that our 0 to 2s have been really impacted, and there has been no additional government funding for the early years sector. So what we've actually done is we've put in a bid, and we're very grateful to the council for providing a bid that will allow us to work more with speech and language and communication for those children who've not had that opportunity because of COVID. We want to work to help sure that children can get their physical development where it needs to be, having missed out, to provide those experiences and opportunities. We want them to have personal, social, emotional development, and again, looking at working with families to make sure that those children catch up for those things they've missed out. We're also going to do some parenting support, and we're also going to make sure that those children who've got special education needs and disabilities will have some additional targeted support, so that those children who haven't experienced socialisation during this last 19 to 20 months can do some catching up, which of course they'll need very much so in order to make sure they're school ready and they have all the opportunities they deserve as they're growing up. We had a bit of a peak during COVID of serious youth violence. We've had 2 very sad murders in Reading, as you'll know, in January and February, and we had a number of serious incidents last year. We haven't seen any particular increase more recently, which is really good to note. But what we're doing about the serious youth violence is to look at the learning from those incidents that have happened, to see what the impact was of COVID and what other impacts and trends there might have been, but to really understand what's happened in that and looking at that with our colleagues in the Youth Offending Service. The Education Welfare Service, which interestingly sits under early help and prevention, but you'd think would come under the schools, but it doesn't. It actually sits under early help and prevention, are continuing to provide a lot of support to the schools. For quite a long period of time, we provided those services to the schools free of charge, and we have gone back to trading on some of those services for some of the additional services that we have been providing, and we're really very pleased to report that the schools have taken up those offers, and so we feel very much that we're going to be able to provide additional support for those children again who may be disenfranchised, and be able to differentiate between those children who may be having authorised absence because of well-being issues or having COVID, or somebody in the family having COVID, and those families who are perhaps not being as proactive as they may be, or using COVID as a cover. I'm absolutely sure there aren't many of those families, but we do know that for some families, they've been really quite frightened and overwhelmed by the potential impact of COVID, and so haven't been sending their children to school in a way that we would want them to be. And then the other two things we've got going in, we've got some projects in schools. We've got 2 projects in schools with Moorlands and Prospect School, and with the Royal Berkshire Hospital, to look at early identification of issues that are coming forward, so that before situations become more embedded, before families needing to be referred through to social work services, we're working with schools and the hospital for some early identification of those situations. And that's, something that we've been put in during COVID to recognise the need to identify children at the earliest possible point. So again, we'll look forward to being able to report back to you at some point in the not too distant future about the impact of those projects. Thank you very much.
Great, thank you, Deborah. Any questions, any points? I mean, it's concerning around the increase in poverty, and of course we've got the biggest cuts in benefits, I think, in history, as happened just a couple of days ago with the cuts to universal credit. So I guess that's going to be something we're going to have to really be prepared for and to to respond to. But that's going to be really tough, isn't it? I haven't got anybody else indicating, or I can ask questions. So in which case, we've got a very comprehensive overview anyway. So thank you very much. Thank you very much, Deborah. Okay, in which case we shall move on. We've got, it's influenza is the next one. We've obviously covered a fair bit of it. So I don't know who's going to take this.
Be me again. So you've got a paper that is part of your pack. To sort of say, just as a highlight, the paper just goes through the eligibility, which obviously has been expanded, which now incorporates also children aged 2 to 15. It's continuing with those people who are over 50 as well. So it's a big ask. I think the thing to note realistically is the key risks for Reading population are the fact that obviously with the relaxing of restrictions, people are now more likely to socialise. Therefore, there is more of a risk that actually influenza might become an issue for the country going forward. So it's a really important thing that actually people are not only having their code of vaccination, but they also take forward the opportunity of having their flu vaccine as well. So at the moment, the programme has just literally kicked off. We're going into, people can go into their GP practice, they could be going into their community pharmacy as well to actually have an actual vaccine. The Uptake Ambitions is the fact that is set out in the paper. So we're hoping that for 65s and overs, that we're hoping to meet a target of 85%. Under 65s rather, who are at risk, 75%, and then for 50 to 64, 75%. And this is a really key target for us. And obviously, we're also trying to encourage all health and social care workers should be offered a actual influenza jab, but the ambition is that we have an 85% uptake. What's happened quite recently is the fact that across BOB, which stands for Buckinghamshire, Oxfordshire and Berkshire West Integrated Care System, they're overseeing now the actual rollout of the actual flu vaccines. There is meetings that happen on a fortnightly basis. Our Berkshire West level, we hold there's a weekly meeting across all of the providers, as well as bringing in social care that looks at vaccine uptake. So we are actively working on a previous model that we actually successfully rolled out from the previous year. Looking at the last year for the uptakes, generally we did quite well from last year. The uptake had increased from Berkshire West from where it was in 2018, from 73% to 81%. So we had done quite well in 2020, 2021, and we're at an aspiration to really maintain that and hopefully improve on that stated at the moment. Obviously, we're going forward with also looking at the information about those people that are possibly the most hated and also the seldom heard groups, so actively monitoring on those groups of activities as well. And you've got some information in the chart here as it is at the moment. So rather than go into much other details, Chair, I'm happy to receive any other questions.
No, thank you. I think you covered a lot there, and you sort of wonder why we've got this separate. We've discussed a lot of the issues, but I think it's really important to have the data and the targets and to really understand where we're at and some of the challenges as well. So I mean, I suppose you covered it. One of the things that I might have asked was about learning, about the more successful to less successful, but clearly also in a different world, aren't we, this year? It's going to be very new in terms of so many more hoping to be vaccinated. And I will say, I completely agree with you. I think flu could be a real danger this year, both in terms of the pressures on the NHS, in terms of people ill, but also in terms of actually being serious risk to people's health, because we've all been keeping away from each other for so long. I haven't got any further questions other than those points. I haven't got anyone else indicating, in which case I suppose thanks very much for the report. I think the data there is important. Obviously we need to come back. We'll see what how we go against meeting those really important targets. Thank you. No one else is indicating. So we'll move on then to the Berkshire West Health and Wellbeing Strategy, 2021 to 2030. Meredith.
Right. Yes, I'm very happy to present this. Yes.
Thank you.
I wasn't planning to go through it in detail. The whole process has been here a number of times, and a number of this committee have been involved in the process, which is great. It's come here for decision today, decision to sign it off, as with it'll also be going to Wokingham and to West Berkshire Council. And if anybody wants to have a look at the engagement report, it starts on page 100 and it's quite considerable. And there are 5 priorities identified. People wanted as few as possible, so there are 5 priorities. And the plan is, in terms of the delivery, is the indicators that were in the original consultation will be used to monitor delivery of this. But there will be 3 local plans delivered. So Reading will develop its own plan with its own indicators. And so once this is signed off by the Health and Wellbeing Boards, it will then go to the Integrated Care Partnership, and that's what it's called at the moment for Berkshire West. And so this is more of a bottom-up process from the Health and Wellbeing Boards. So the Integrated Partnership, the benefit there is there are 10 partnership boards, and each of those will develop a plan to deliver this strategy. So what I'm asking today is just if people are happy to sign off the strategy so we can get on with the delivery.
Thank you, Meriden. And yeah, I mean, some of us have, I'm best be careful, because some of us have seen this a lot as it's been developed. And I think one thing I was pleased with has been, yes, there's been a long development process, but it's also been a real process of involvement across the people that need to be at the table, which I think is really pleasing. I think it's a good strategy. I think the one thing that I've learned through the development is how we are often, I think particularly people in Reading and maybe Woking, West Berkshire, talking about trying to achieve the same things but using very different language. And I think so this strategy doesn't necessarily say the things in the same way that we did in a Reading way, but actually you know, when we're talking about health inequalities, it's right there, you know, central. Also, non-surprisingly, one of the things that was coming through very clearly right across the board was around mental health, you know, in terms of the impacts we've had over the last couple of years. It's not surprising that's come up, and that is obviously within, you know, 4 and 5 those priorities there, so that, you know, you get a sense of how important it is. And also young people and children, you know, these are people that really, you know, real big impacts from the last couple of years alongside inequalities and that impact. So I think that fits. What we're actually going to be doing, it does come here, and obviously we want to endorse, well, I recommend it endorses, you may all say something different, but endorse this strategy here. It then goes to the full council, Reading Council, where the council adopts it formally. And within that, the recommendation will be that the action plan or the implementation plan will then be delegated back to this body to sort of take responsibility, be accountable for, because actually that's going to be the really important bit, isn't it? Is actually this is a really good strategy. Actually, how we deliver that and actually actioning, you know, the improvements is the really important bit, and that will come back to here in terms of accountability, and that'll be a really important part of our work that we do over the next 10 years. And there's also, I mean, it is 10 years is a long time. I suppose the other element is that, you know, we will have a process of reflecting on the strategy and its appropriateness as we move through those 10 years as well, will be something we also do. Right, so I haven't had anybody indicating any questions. Lots of people have seen this before.
Jay, you've got Becky Pollard wanting to speak.
Yes, Becky.
Hi, thanks Meriden for presenting. And yes, I just wanted to say, you know, a lot of work now has to go into those implementation plans to make sure that they do deliver against those 5 priority areas, and it's great that the integration boards and the delivery boards will support in that. And I think we were looking, as you say, in terms of refreshing, looking maybe at a 3-year time scale, but then that's a rolling refresh as we go forward. But one point I'd just like to make, and really a request from the board, is that we've done a huge amount of public engagement to get it to this stage. And I think we feel that that engagement should continue with the development of the implementation plans. And that in itself is, you know, quite a big task. And it would be just asking board members to give us support, access to their networks, so that we can get that real continued meaningful engagement going forward.
Thank you, Becky. That's a really important point, actually, and one that is vital, because actually co-producing that wider involvement and engagement with the delivery and action plans is really important. So hopefully that's something that everyone here will sign up to, and it will be really important. And actually, I suppose it's one of the reasons why the process of developing that, whilst the action's happening and the work is going on, it won't be necessarily we won't do a quick and dirty and get it, slap it down and endorse it here and now. It's really important we go through that process over the next months before bringing it back, so that people are, you know, really involved, because we won't get the best action plan, we won't get the best implementation plans unless we do that. Okay, thank you. Meriden, is there anything else you wanted to add? Was that don't have to?
No, I think that's fine. No, nothing else I want to add.
Great. Okay, I haven't got anyone else. Andy Czerski, Vice Chair, I'm happy to endorse. I'm taking people's silence as happy to endorse the strategy. And Katie Summers just said the CCG has endorsed the strategy as well. Okay, great. In which case, sorry, my daughter's arriving home. And the dog. I'm going to quickly move on to the next item, which is the future in mind. If we could, if we can move on to that item, and I'll let my daughter in and deal with the dog. Thank you.
Hi, I'm Deb Hunter. I am the Principal Child and Educational Psychologist and Mental Health Lead at Brighter Futures for Children. And I'm going to present the Local Transformation Plan update on behalf of Andy Fitton and Nikki from the CCG. So I have put together, you've all had the paper, so I'm hoping that you've all had a chance to read it. So what I've done, just to give you something else to look at really, other than me, is I've just put together 5 slides or so from giving us the summary of our local transformation plan, taken directly from the paper. So just let me start that one. Can you see it? Yes, I think that's okay. Is that all right? Thank you. Okay, so this is, I think, our 6th, well, it should be our 6th iteration of the local transformation plan, following Futures in Mind in 2015. We didn't do one last year because of COVID, it was extended. And I think the first thing to say is, you know, it follows on really well from our previous speaker, because this is the local transformation plan it's about how our local system works together to transform mental health and emotional well-being services and opportunities for children and young people. So it's like our strategy that goes across Berkshire West. And then within that will be tied very closely to the local, each local authority's mental health and emotional well-being strategies and the well-being plans that have just been shared. So there will be close link, and we want that synergy that goes across. And it will also, what we try to achieve in our local transformation plan for children and young people with mental health and emotional well-being needs, will link so closely to our SEND strategy, for instance. And I think it's just important to make sure that if we're going to achieve system change for mental health, then it has to go hand in hand with system change for SEND, for instance, and well-being. So even with COVID, we were cracking on, which was great. There was, I'm just making sure I'm on the right slide there. We undertook a review of neurodiversity needs. Sorry, I just wonder if I beg your pardon, I've gone on one too many slides. So let me see if I can go back. Okay, that's it. So we continued across Berkshire West and within Reading, we continued the mental health and emotional wellbeing services. I've abbreviated that to MEW, MHEW, mental health and emotional wellbeing services. And we continued those during COVID. In a blended model, we had a lot of virtual work going on, so children and young people were still able to access CAMS, primary mental health, educational psychology, our voluntary organisations, either directly through the phone or text, or a combination of Teams and Zoom, with all of the carefully thought through safeguarding measures that were developed as part of that. So I think that's a massive achievement that shouldn't be underrated, really. Also, we know that just before COVID hit, mental health needs were rising and have been a government focus for the last 6 years. And what happened during COVID was that we saw, again, increasing demand and complexity of cases. And it's that complexity, I think, that really needs to be acknowledged, because that means it has a direct impact on our wait lists if children and young people are needing longer interventions. So it's not just that we've got increased demand, it's that we need to make sure that the children and young people have the service as long as they need it, or as long as it's appropriate, which impacts on wait lists. A big achievement was over the last 18 months is we have 3 mental health support teams across Reading, Wokingham and West Berkshire. And we now have a further 2. So we have, as Deborah Glassbrook said just now, we have a second mental health support team here in Reading. So that's 2 out of our 3 areas in Reading that are now covered by those teams. Our second support team we have appointed. We have 1 vacancy left to fill, which is fantastic. It goes live in January. We have our education mental health practitioners who are currently training at Reading University. They come out to placement with us in January and then start accepting referrals, and we're really up, live and running with a comprehensive service from September of next year. All of the mental health support teams across Berkshire West are very good at flowing their outcomes up to the national data set, and our data is in line with other national data, which is great. Within Reading, we're doing a lot of work on building a dashboard so that we can look at live mental health data to see what the themes are, where we're putting our resources, what our outcomes are. There's a lot of success that carried on over COVID was large-scale training with our partners. We ran several modules, both in Reading and I need to say across the other two, as this is part of our local transformation plan. An example that was quoted in the plan is the training we've been doing in Reading about being trauma-informed and our therapeutic thinking schools approach, which has been very successful in bringing down numbers of fixed term and permanent exclusions from schools. So in 2016, we had one of the highest rates of exclusions in Reading schools, and earlier this year, just before our SEND inspection, we were very proud to be the best in the country for having the fewest number of exclusions in schools. And the big shout out to our schools who have really embraced that way of thinking, and a credit to them really. So other achievements, we undertook a systemic review of neurodiversity needs. Waiting times for ADHD and autism remain a priority, but the CCG have been able to procure significant investment to recruit staff and also to invest in digital assessments for neurodiversity, with the ambition of bringing that waiting list time down to below 12 months. Really good news in that we've had 2 significant joint transformation programmes. We have agreed a children in care service, although we tend to call it our children looked after service in Reading, and that will be a mental health and emotional wellbeing service specifically for our children in care, and it is being commissioned jointly across the 3 authorities and the CCG, and there will be a team of clinicians employed care, excuse me.
Brilliant, not just me. It's almost like thank you very much for making me less embarrassed about my dog.
Sorry about that. Yes, that would be, hubby coming home and the dogs welcoming him. So our CLAR Mental Health and Emotional Wellbeing Service, located within Reading with our social care services, employed by our colleagues in BHFT, a really good example of close partnership and system working. So that's very exciting. We have also, across the 3 authorities, got a new intensive community and home treatment offer that will be hand in hand with our rapid response offer. And that's very exciting. We had a case last week that looked at how that might work, and the family, I think, was feeling very supported. BHFT have transformed their Tier 4 offer. So the existing 9-bed Willow House inpatient offer is being stopped, and it's been recreated as a hospital at home offer for 16 children and young people, with intensive care for the child and the family in their own setting. So I think one of the biggest developments over the last 18 months, and Deborah is here, and I know we'll be able to answer any questions about this if needed, is the Berkshire West Integrated Care Partnership Board. and that the last 18 months has seen consolidation of the joint governance arrangements across health, social care and education. And the ICP board has sponsored and will be leading and giving us governance on agreed 9 transformation priorities. These 9 transformation priorities were identified following a review of all our mental health and emotional wellbeing services, looking closely at gaps and then agreeing the way forward. And those will be underpinned not just by strong governance, but by financial investment from across the service, across the system. I've just listed the 9 transformation priorities for you. They are in the paper with more detail, but you can see that it's really, we continue to use the Thrive model in trying to bring about system development as being the way forward for improving our mental health and emotional wellbeing services, so that children and young people can access them where and where they want to and where and when they need it. And it would be unfair if I didn't also just alert you of what the challenges are that we've outlined in our local transformation plan. So I alluded earlier to the increased demand and the impact on wait lists. So CAMHS in March 21 reported their highest number of referrals ever, and that was just as school lockdown was easing and returning to schools. It's important to say that in trying to meet that particular challenge, every provider has put something in place for children and young people who were on the wait list, and that includes things like triaging, offering them interventions such as a sports intervention, and signposting to self-care and online services as well. We also, as I said, have increased complexity, and 2 examples quoted in the plan were the increased risk management for learning disabilities and autism, and we're seeing increased complexity of presentations of disordered eating and eating disorders. Workforce recruitment and retention, as ever, is an issue for trying to find psychologists, clinicians, social workers. It continues to be a problem. The neurodiversity assessment waitlists I've mentioned. Our families have told us that our mental health offer is good, but there's a lot of it out there. And actually what we need to do in the next step is to make it easier to navigate. So when you look for a service, you'll know whether or not that service or which of the available services is the one that will be most appropriate. And an identified gap that we will be looking at is the mental health of children and young people who are either on a child protection plan or a child in need plan. Okay, so I'm going to just take those slides down so that, you don't want that. You give me a minute here. There we go. All right. So you can see my messy desktop there. So Chair, that's the end of my summary. Over to you. Thank you.
Great. Thank you for that. I think that was very comprehensive. I'll open up any questions, any points people want to make. I mean, it's a familiar picture, actually, isn't it? In lots of ways, lots of good work done and progress being made, but within the context of waiting lists and quite frankly, an underfunded area of care, which, whilst there may be some improvements in funding, still doesn't catch up with the needs. And I suppose the worry is that with the couple of years we've had, and quite frankly, you know, kids have had a rubbish couple of years, haven't they? How the system will cope. I suppose I think the money thing is just the money thing. There isn't enough of it in terms of resources. I think many of us would agree with that. My question is there an impact in terms of meeting those waiting list targets, in terms of labour force, in terms of staffing? I know that some of Berkshire Healthcare Trust, when they've talked about some of their mental health services, have identified Brexit and, you know, what kind of immigration policy there might be would be a risk. And I just wonder whether that is a risk for us over the coming years in terms of meeting these targets.
I think that's a really good question. Certainly the waitlist is not helped by difficulties in recruitment. And if we were fully staffed, we would be able to meet more needs in a quicker way. And it's about how we manage to recruit, how we make the jobs that are the vacancies appealing to people. And then how we ensure that we support our staff who are with us, well enough so we don't lose them, because all of our staff that work in mental health, emotional wellbeing, could walk into any job in any authority, and so it's really important that we extend our trauma-informed approach to the staff we work with, and that we recognise the stress that the job puts them under, and that we ensure that we give them adequate support, supervision, and so on. Yeah.
Okay, yeah, well, not an unusual challenge, I think, for public sector in this area. Full stop. Okay, thanks. I haven't got anybody else indicating. So thank you very much. Thank you for that presentation. So really good and hard work being done in really challenging area. That's and really important.
Thank you.
Okay, thank you very much, Deborah. Right, so our next item is the SEND strategy and inspection update. The other Deborah Glassbrook.
It's rather marvellous that Deborah's working together this afternoon, so thank you very much. So this item is to share with you, and Ramona is going to join me because she'll have some wonderful things to share about her experience in terms of developing the SEND strategy and also the inspection. So if I may, I'd just like to give you a sort of summary of what our local area inspection was or consisted of in June of this year. So it took place between the 21st and the 25th of June, and it involved all our health services, the schools and the borough, Brighter Futures for Children and Reading Borough Council, hence it being called the local area inspection. So the inspectors spoke to children and young people with special education needs and disability, their parents and carers. We gave 2 presentations to them at the start of inspection, and there were 23 focus groups during the week that they were with us. They visited 8 different settings, despite us being in sort of semi-lockdown at the time, and 140 colleagues across Reading met with the inspectors, which I think is fairly phenomenal. It gives you that idea of just how robust the process was. We uploaded 99 documents to them, and we shared 115 education and health and care plans that they were able to scrutinise and assess and check that we were doing the right things. So the feedback that we got, and I'm just going to give a synopsis because in the SEND strategy you'll see the fuller detail, but what the outcome was that the quality of care for children with SEND in Reading was improving and is continuing to improve. They could see we got a determination to make Reading a good place to be for our children and young people with special education needs and disabilities, that the leaders recognised and have plans to address the issues that our parents worry about the most, and I'm sure Ramona will be able to say something about that. That as a professional group we work well together, and I think that was a real strength across, that even though they found things that we were not yet doing well enough, we had really strong plans in place and could evidence knew our business, we knew what we needed to do, and we had plans to work across the partnership together. They were able to find that there's much earlier and better identification for children with SEND, although they did give us a great challenge, which was about how do we recognise that there may be children that we are missing. So that was a real conundrum, how do you find children that may be missing? And that's something we've given a lot of thought to, and certainly the piece of work I mentioned earlier on about the levelling up for our 0 to 2s and how we're working in partnership to identify that will certainly help on that particular challenge from the inspections. They found a number of examples of established co-production and joint work to identify that early work, and that is something that we're going to continue to strengthen as part of our SEND strategy. Schools and early years settings were considered to be well supported by education and health services, and they found that schools had collaborated really well to make the curriculum support all pupils to learn. And we know we've got some really wonderful schools that work in a very inclusive way for our children with special education needs and disabilities. Deb Hunter has already just talked about the number of schools that have reduced the number of exclusions to the point that we are one of the top areas in the country not excluding children. And again, that was very much picked up with in our inspection as well. So one of the quotes was that the improvements to services are planned and delivered in genuine partnership with parents and young people included as standard. And you know, I think that's absolutely true. We do very little, if anything at all, without engaging with our parents and our children as we go through. Our outcomes for pupils with education, health and care plans are in line with or above the national average by the time they leave primary school. And again, I think that's something that's incredibly important and that we continue to work with. And we know that in our secondary schools, pupils with SEND attain better results than their peers nationally. Again, something that we can be really very proud of and want to continue to work on. And of course, the thing that we have been doing is having some capital programs and working on delivering some more schools and more school places for our children with SEND, so that there are those specialist placements so children and young people don't have to go out of area. And we also had feedback about the widespread awareness among families about where to go to get advice and support when they need it. Now, of course, there are a whole range also of areas for development that they highlighted for us, and you will see those outlined in the SEND strategy. But I think what was really good is that we did not get what's called a written statement of action. Now, a written statement of action is provided by the inspectors if they don't believe that there is the confidence and competence in the local area to address those areas of need and improvement. And I think it is really good to note that the majority of local authorities in this country did get a written statement of action in their first inspection, and we didn't. So we have linked the feedback, and I've given you the positive feedback there, and forgive me for not outlining all the other things. But before I move on to talk about the SEND strategy and what we've done, Ramona, is there anything you'd like to come in at that point just to add?
Yeah, no, I think from Parent Carer Forum perspective, we felt it was very fair Ofsted inspection. I mean, a lot has been working well in Reading, and it's a credit to everybody in Brighter Futures. But you know, I think what they picked up as well is that families on the ground don't always see the difference, and that's about communication and about making sure that people get a better response when they go through the front door as well. And I think, but overall, we thought it was really positive and very fair.
Thank you, Ramona. Super. So what we did was we took the learning. So some of the things that they identified we needed to work on was the waiting times for the assessments. And Deb's just mentioned again about the amount of additional resource that the CCG have identified for that, improving the identification of needs for the 0 to 2s. And I mentioned that in my earlier bit, getting children with SEND ready for school, ongoing development of specialist education places, and ensuring that all elements of the children's education health care plans are strong. That's particularly looking at social care and health input, and then strengthening the offer for young people with very complex needs, and especially those who are 18 to 25. And you'll see that again, as I say, reflected in the new strategy. So if I may just move on to the strategy, we needed to update the strategy. Our original one was running out at the end of this year. So the strands of the strategy, all of the people who are part of this SEND strategy group have come together, and huge thanks for all the time and effort that's been put in, both to actually carry on working on those strands, but also to update the strategy. So as you will have seen in the pack, we now have a strategy from 2022 to 27, and we have expanded from having 5 strands to include now a 6th strand, which is looking at capital and school places, so looking at sufficiency, again to reflect what the inspection said, and a strand 7, which is around finances and funding going forward. And what you'll see in the strategy is a great deal of detail and data around the work of each of those strands and their action plans, and that will be a continuous piece of work going forward. Now, we are slightly disappointed that we were expecting some update on SEND reforms from the government. We've had their third delay in that, and at this point in time we don't know when those reforms will be published by the government. So we have continued to do what we know is best for our children here by developing this SEND strategy, and if there are some changes and updates required once those reforms come through, of course we will reflect those in the strategy and of course bring that back here for any further communication and ratification. I don't think I need to go through any more detail, Councillor, but I thought, that we wanted to bring that the new strategy for everybody here to see, and to be able to celebrate on the achievements of the local area, both in terms of the inspection and this strategy. Thank you very much.
Thank you, Deborah and Ramona. That was really good to see some well, we sort of had these updates, don't we, and progress being made, and it's good to see that from the outside and in terms of an inspection as well. So thank you. I haven't got anybody else indicating. That was a really good run through. It's a really important area. I don't know if Christine Stannard was you indicating because you want to, you may just no, she just come up. Is it for the next item? Right. Okay. So thank you very much. We will move on to the next item.
Thank you.
Christine Stannard has presented herself, jumped up in front of us, and that is the Berkshire West Stop Smoking Service e-cigarette position statement.
Thank you very much, Chair. My name is Chris Stannard. I'm the Public Health Programme Officer in the Council. You will have had the report talking about the new Stop Smoking Service, which is being commissioned jointly across Berkshire West, and also including, for information, the new South East Directors of Public Health position statement on e-cigarettes. So if Nikki could please put up the first slide. And while she's doing that, just to put some of this smoking into context, in 2019, just under 14% of 18-year-olds in Reading were currently smoking, and that's equivalent to 17,400 people, which is broadly in line with the England figure, but clearly there's still more work to be done. And we know that the prevalence of smoking is much higher in certain groups. And I can come on to that. I think it's important to say that the Stop Smoking Service is part of a much wider piece of work around whole tobacco control, and it includes not only the work of the service but our other partners across the system. So the recent money that's been allocated to the NHS for the development of the tobacco dependency treatment service in maternity, mental health and in inpatients is going to be a really important addition to help bring those numbers down. And we're all working towards the government's ambition for England, which is to be smoke-free by 2030. So the key features of this new service, essentially it's unchanged from how it has operated before and has continued to operate. It's still an evidence-based standard treatment programme for dealing with tobacco and smoking. It's available to all smokers or users of tobacco products in Berkshire West. And support can be gained either face-to-face, via telephone, via an app called Quit with Bella, and there's some self-help resources as well. It's available 7 days a week, 52 weeks a year, with services open evenings and weekends. What is different about this new service is that there's a greater choice and flexibility of routes to quitting, which takes into account people's circumstances and the amount of commitment they wish to put in to quit attempts. The service will continue to offer the full range of pharmacotherapy, which is nicotine replacement therapy, but it is important just to flag up, in case anyone hasn't heard, there is currently a national shortage of Champix, which is one of the medications which the service can give, and that's due to a national shortage, and so no services are able to provide that at the moment. The service is keeping a waiting list for when the supply resumes, and in the meantime people are still being offered that behavioural support and the nicotine replacement therapy. The service is e-cigarette and vape friendly, which is great because I'm going to come on and talk a little bit about that in a moment. And what is really important is that it's going to continue to be targeting at priority groups at high risk of tobacco-related harm. A health needs assessment was carried out a year or so ago, and these were the groups that have been identified, as you can see. So the routine and manual workers, pregnant women who smoke, which is also great because they will be targeted through the tobacco dependency treatment in the hospital, people diagnosed with a long-term mental health condition, individuals receiving treatment from substance misuse services, those that are currently admitted to secondary care acute settings and or living with one or more specific long-term condition. Again, that will be subject to this new funding coming into the NHS, which is fabulous. And children, young people under 18, and those in certain minority ethnic groups. So if you can move on to the next slide, please, Nikki. So the new model is a tiered model with different levels of support, which is where the greater choice and flexibility to smokers comes in. So it's called the Stop Smoking Plus model, which is an evidence-based model from Robert West. And if we start at the top at level 3, this is where we have the specialist stop smoking support. So this is where we will be encouraging smokers in those priority groups to enter at level 3. They will have a minimum weekly contact with an advisor for 6 weeks, and their smoking status will be assessed at 4 and 12 weeks and validated by CO Monitor. Then if somebody feels they need less intensive support, they can still come in at level 2, which is where they will get brief advice from a smoking advisor and pharmacotherapy, as indeed is prescribed for level 3, and the smoking status is assessed at 4 weeks, again CO validated. At level 1 is where we have the digital-based information and support for those people who want to quit on their own. So there will be a clinical assessment, however, and the smoker will be routed to the best level of support for their level of dependence. I think that's important because we know that the more successful quits are going to come with that behavioural support and the nicotine replacement therapy. But they will also have access to the Quit with Bella app, which can take them through a stepped approach to quitting and receive encouragement and prompts along the way. So it's not very visible, but the referral pathways coming in, people can self-refer or they can be referred in via their GP or through pharmacy. And I think it's important that the triage is what is going to take place so that smokers understand the different interventions at each level and what the likelihood of a successful quit is and the commitment that is required to achieve that quit. And I think it's important to say also that if someone is unsuccessfully not able to quit, then they can re-enter at the same or a different level. So it definitely reflects people's choices and people's preferences for different levels of support and what they can commit to. And I think the training and marketing side is also really important. As I mentioned, the link with the NHS trusts around the rollout of tobacco dependency treatment services is going to be really key. And I understand that the service is already looking at providing training for the new stop smoking advisors who will be working in hospitals, which is great. And also maintaining and strengthening the links with our GPs and pharmacies, taking part in general awareness campaigns such as Stoptober, and also importantly part of that wider tobacco control agenda. So that's briefly, very briefly, the service as it stands today. So moving on, I really wanted to draw your attention to this. It's a new position statement on electronic cigarettes, and it's been developed by the Directors of Public Health across the southeast of England. And it's in response to emerging evidence and some myths, misconceptions, and different messages that have come out about the safety or otherwise of e-cigarettes and what the advice is from a public health perspective. So this is a comprehensive guidance, and as I said, it's a regional public health consensus. It goes through all the, it's a very long document, I should warn you. It steers through all the latest evidence, best practice and the relevant regulations that are the impact on e-cigarettes, and it summarises those key communication messages so that practitioners who are talking to clients and patients are all giving consistent messages about e-cigarettes and giving that evidence-based advice. So it's encouraging a consistent approach for all of us when we're talking to people about e-cigarettes. And I think also it can help organisations to develop their own policies and practice in that area. So I won't go through all the huge detail that's in there. I don't think it'd be possible, but I really would urge you to have a look at it. And if you are in an organisation, then you have your stop smoking policy in the workplace, then I think do have a look at how e-cigarettes can fit into that. And if you're a practitioner, do look at it to see those messages that you give to clients. So we are giving a consistent approach. That was all I was planning to talk about, Chair, so happy to take any questions.
Double clicked on my mute button. Great, thank you very much for that. I think that was really covered the area. I mean, I always find the stop smoking stuff is, well, it's a deeply frustrating area in the sense that it has been affected by the large cuts from the government to our public health budgets, and it's really, you know, if anything is a false economy, the cuts that the government have made to our public health budgets is absolutely one of them, and I think that does has affected the way that we've had to approach the smoking stop smoking service. However, it's about making the best of a difficult and challenging situation, and I think that's obviously what we need to achieve and have done previously and need to achieve with the future retendering.
And I think the effective targeting is where we're going to get the wins. It's harder, but it has to be done.
Yeah, no, I think that's absolutely right. And sorry, I'll ask if anyone's got any points. I think in the past, and I think this is, I mean, I won't, you know, distant past, I think there was very much a, had been a bit of an approach of taking the easy, low-hanging fruit, which is often middle-class people that are easy to get, and you cranked up your figures quite easy. But unfortunately, that didn't do so much in terms of the health inequalities that we see. And actually, sometimes the harder groups to shift in terms of behaviour are the ones that we really need to be getting into to support.
Yes. And I think it's just reinforcing that making every contact count message again, as well as having your specialist advisors either in the service or in the hospital trust, which is great news. But I think it is making every contact count, and you know, if everyone can play a role in that and be signposting people to support, I think that would all help as well.
Right. Thank you. Anyone else indicating other than Meriden Beachy said excellent presentation, Chris. So,
thank you, Meriden.
Thank you very much. Thank you.
All right. Thank you, Chair.
Thanks a lot. So our next item is the Berkshire Suicide Prevention Strategy. Sushma, is that Sushma Akir? We saw you earlier. I don't know if the trouble you had switching your camera off replicates the difficulty of switching it on.
Can you see me? I think you can see me now.
Yes. Right. Brilliant. Thank you.
And even I could unmute myself because that was another problem.
No, thank you. And
technology hasn't been great with me. So if I could say something in the introduction, first of all, thank you first of all for giving me opportunity to present this. This suicide prevention strategy was actually developed and produced by the Suicide Prevention Group of Berkshire, where people with the great interest in the topic developed it. Karen Buckley, who was the consultant in public health, was leading this. And when she presented it to the group, it was for basically her last meeting was to accept this strategy and ready for dissemination. So the status of this strategy is that it has been accepted and adopted by the suicide prevention group. Now I'm bringing it to all the health and well-being groups so that they can accept it and adopt it as it is, or adapt it for the local implementation, because all the implementation would happen at the local place. Since I had very limited time to get familiar with the whole system, I chaired the last meeting and I listened to the strategy, and it's really great, and I've read bits of it as well. I may not have the detailed in-depth knowledge, so I am kind of putting my hand up by saying that. What I have done with the previous presentations, that I've actually gone to the councils and taken the questions. So if I can answer any questions, then I'd be more than happy to do it. Otherwise, I might have to take it back to the suicide prevention group and see whether they can modify it. One of the questions that arose in another meeting, and I think it's an important issue, is whether we've had any public consultation on this particular strategy. And to my knowledge, we haven't. And maybe I think one of the tasks that would be for the next meeting would be to take it back and say whether they would like to have a public consultation, whether that public consultation needs to happen in each of the local authority, or should it happen for the whole of the Berkshire. Because it's already been written, and as far as I understood with the limited knowledge that I had after chairing that meeting, was this is the strategy that has been developed over the last 2 years with great effort from people who were expert in the subject and who had great interest in this particular topic. So I don't know how you want to play it with your time and everything. I was thinking if I could just do the initial 6 slides or something, and then leave the details for people to read it in their own time. Or if you want me, I could take you through the whole presentation. What would you prefer?
No, I think that's fine. If you do the initial few slides, I mean, I've had a bit of a read. I think it's an excellent strategy, but I'll come to my views in a moment. Yes, and then we'll open up.
Yeah. So the local strategy is based on the national strategy, and the national strategy themes were that there is a requirement to reduce the suicide in high-risk groups. We need to tailor our approaches to improve the mental health of the specific groups who don't just kind of go into the suicide, but they also have the behavior which demonstrate earlier. We want to reduce the access to the means of suicide. And by that means, I think when I was going to the resilience group, etc., they have identified high risk spots in the county or in the areas. If we could reduce those means, we need to provide the information and support to those who are bereaved by this and affected by family member who whose life has been lost as a result of suicide. We want to promote sensitive media reporting, and we want to support the research, data collecting and monitoring. And in all this, reduce the self-harm, which sometimes is the precursor of the suicide that we see. Next slide, please. The method that was used was the previous Berkshire suicide prevention strategy, which was 2017 and 2020, was taken as the basis to modify the existing strategy. They utilized the expertise of the members on the long-established Berkshire Suicide Prevention Steering Group. They try to engage with the professionals who are working in statutory, private, or the public organizations and the third sector organizations and are interested in the suicide prevention. They've established a Berkshire Suicide Prevention Strategy working group. So there is a big group and there is a small working group which has been working on it. and the small subgroup of the suicide prevention steering group was responsible for further defining the content of the whole strategy. Next slide, please. The data that were used were the ONS data, and recognizing the difficulty of the ONS population data also, because we are into the estimated data, and I understand the ONS data from the recent census is going to be delayed. We looked at the suicide prevention audit of 2018 and the NHS audit of 0 to 25. There was a deep dive done for the female suicides. And I know this is something question people asked. Male suicides seem to be more. However, in Berkshire, we do have more of the female suicide in a certain age group. And we also, or the group looked at the impact of COVID. Next, please. So the areas for focus for the Berkshire strategy were children and young people, women, those who do self-harm, those who have economic pressures, and those who are bereaved or affected by suicide. If the family member has been affected by suicide, then we try to provide the support for them. The overarching recommendation, and that's why I said, let me go to the general ones up to the 5, where we look at the overall recommendation, is we continue to monitor the impact of COVID-19 on suicide. And I think there was a lot of national data saying COVID-19 may increase the suicide as a result of economic pressures, but that just still needs to be seen in terms of the data. To continue and monitor the wider trends emerging from the impact of COVID-19 on people's mental health, if it is not necessarily just the suicide, how their mental health is affected, and if we can provide any support within the system for whatever action is required. To undertake a Berkshire suicide audit, and I think there was another report which was released 2 or 3 days ago on suicide audit for the children, and that wasn't included as a part of this because it was only released in the last 2 or 3 days. We take regular reviews of information and resources and channels for people affected by suicide. We hold an annual multi-agency conference, that was another thing suggested, on the range of topics to share the information and the best practice and how we can reduce the risk of suicide. We invite additional partners across the systems within the Berkshire, including the voluntary and community sector, to join the suicide prevention group. And then finally, set up a subgroup or suicide prevention group informed by local intelligence and data where there is need to focus upon the risk factors or group within the population. So I think those are the general recommendations. If we go through the other slides, then it kind of goes into deep dive into children and young people, then women, all the priority groups, and quite a lot of the recommendations might be the repeat. So instead of wasting time here, I think it would be good if I could take any questions or any comments from people. Thank you.
Great, thank you for that. I think the point around involvement and consultation is a good one. I raised this myself, and this is it's Berkshire-wide. It's also a refresh of the strategy we had before, in lots of ways. And also, if you look at the document, there's a wide-ranging prevention group which involves a lot of the groups, the voluntary groups, community groups, and professionals that you'd want to include in that. We are going to, require, contradict me if I'm wrong, a local action plan, implementation plan to do that. So my feeling is that actually what we do on the ground, I think it's really important, that the consultation and co-production around that, I think, will be really important. It may be, just off the top of my head, the thing where we do concentrate that wider involvement within Reading is kind of my view, but obviously interest in others. I welcome this. I think I've seen, it's a difficult area. I've seen quite a lot of these strategies around actually when we had the first Berkshire one about 20 years ago, I think, and that was a step forward having it. It has come on leaps and bounds. It really does address a lot of the really serious issues. The area is fascinating, and it's something that we always need to be, pushing in order to reduce suicides, which obviously has such devastating effects on people's families and communities. The one thing that I think is clearly, we've mentioned it before, and we talked about economic issues. Is we're going to start to see come through the universal credit cut that's just starting now, and I think that's an area that we're going to, it's difficult to know the impact, but it feels like it's going to be a bad one, I suppose. So I've got Becky Pollard would like to.
Hi, thank you, Chair, and thank you, Shushma, for an excellent presentation. And I'm new to it as well, but I have read it through, and I think the overall recommendations are really important and fit very squarely within the health and wellbeing strategy. And I would just urge that perhaps the adult mental health wellbeing steering group, who I think's agreed to take forward the implementation plan for the priorities in the strategy, sort of refer to this document, because I think there's lots of overlaps and a lot of work's been done and the evidence. But yes, I agree, a really important area. And if we can integrate it and build in what's being suggested in this suicide prevention strategy into our implementation plan for the health and wellbeing strategy, that would be really good. And I guess to acknowledge the work that Karen Buckley, who's on maternity leave, who's done, because I know she put in, and Katie Badger put in a lot of work. But thank you for presenting it. Very interesting. Great,
thank you. Thank you. Yes, and we should hopefully Karen's doing well in her maternity leave. Right. Anyone else? Any points anyone wants to make? No, I think Andy might be coming up for the next item rather than comment on this. In which case, I think we're agreed on both endorsing this and the next steps forward as well. So thank you. Thank you. And if you haven't read it, I do recommend having a good look at this strategy. I think it's I think it's a really good read. But anyway, that's my view. Okay, so the next item is Andy Czerski has come to do the Integrated Care Partnership Unified Executive Report.
Yes,
Andy.
Thank you, Councillor Hoskin. Andy Czerski, GP, Vice Chair of the Health Wellbeing Board. I'm also a PCN Clinical Director, and in that role I sit on the Unified Executive. So the Unified Executive is the most senior ICP meeting within Berkshire West, where a collective of our Chief Executives sit. And I'm just going to present some of the items that were discussed at the September meeting from the Chair report. First one is on place-based delegation. There's a lot of discussion about the configuration of the ICE-BOB ICS, the new Buckinghamshire, Oxfordshire and Berkshire West integrated care system, trying to de-jargon all the acronyms for you. And what the configuration was going to be. There was a bit of a delay whilst various MPs and politicians were trying to sort that out, and actually it's going to stay as it is. So the Berkshire West Integrated Care Partnership as it is at the moment, once the CCG is absorbed into the new ICS as of April next year, are looking at place-based delegation. And this will be the way that decisions are made at a more local level. And that would be at the Berkshire West level. So there's a group of people from the Royal Berks who are working on this place-based delegation on behalf of everyone in all the partners across Berkshire West to see how we would do that, and then looking upwards towards the ICS. So we're working on that. I think everybody's agreeing that it's the right way to go forward, that local decision making is important. And having been one of the pathfinders of ICSs, then we were changed to ICPs. Now we're going to become places. I'm sorry for all the jargon, but we are a pathfinders here in Berkshire West, so we're in a good place, having been doing this sort of work for a long period of time, and hopefully we'll be able to give you some more updates on how this reconfiguration will look like as we go into the new world of 2022. The second item is on the review of the urgent and emergency care strategy. Obviously, this is very topical. As we know, the urgent and emergency care system is under great pressure. It was under great pressure back in 2019 when we started to develop a strategy. Obviously, things have moved on. So it's an evolving piece of work, really. So although the initial improvement opportunities that were developed a few years ago are still pertinent, some of them have matured, some of them are still in progress, and some of them we probably think are no longer relevant as we move into a new world, a new era, and 2 years down the line things move very quickly. So we're having a system workshop on the 11th of November. I literally got the date in my diary today, with the senior leaders across the whole of the Berkshire West Integrated Care Partnership, to actually debate it, not just the people on the ground who work in the urgent care and emergency care system, but our senior leaders as well, to try and prioritise where we need to really put the effort in to unblock any issues, and where do we need to put the plans in place going into 2022. The other item was on rapid community discharge. This was an initiative set up through COVID to support hospital discharges. We knew that hospitals had to clear patients to make space for more patients. It sort of was a positive of COVID because it really focused people's minds on how to get people, once they're fit to leave hospital, out of hospital, rather than leaving them there to get more deconditioned and stay longer. This cost money because you needed teams to actually get patients out and get the right services, whether it's nursing or community social services in place. So there was pump priming for that. And then the money sort of looked as if it might be running out. And so the ICP had to look at seeing how they could fund it. And there was a paper written on how to do a risk share to cover the costs. Actually, the government's coming up with some more money as part of something called H2. It's obviously some sort of central fund to keep this service going until the end of March. What we don't know is whether the funding that will come down to us will cover the whole cost of the scheme, or whether there will still be some cost to our local system. So this is a high priority for the Unified Exec, and they will be carefully monitoring the costs and making sure that the service provided is doing what it needs to provide, and the Berkshire pound is efficiently spent. The last item is just on something called joint commissioning. This is where health and social care come together to make sure that patients with certain needs, whether they be health needs or social care needs, don't get sort of fall between the two providers. Can be quite a complicated area, and I can't say I'm an expert in it, so my apologies on that. But one of the areas is on nursing bed strategy. Some patients don't just need a residential care home, they actually need a nursing home to be looked after, and there's a strategy to develop how many beds are required like that for our Berkshire residents. It's quite a complicated piece of work, so it's actually there's no resource at the moment to do that work, so they're going to push that work into 2022, early 2022, so not too far away. And the other area is where you've got patients who need possible joint funding to be looked after. There's something called CHC, which is continuing health care, which is a national fund to support patients with sort of nursing needs at home or when they're in residential care. But it's quite a complicated area when not everybody who thinks they might have a nursing need actually qualifies for it, or then need is slightly different, but it's over and above what would be provided by general NHS services. So this is another piece of work where they need to look at what are the needs and what are the funding needs for those individuals, and how that can be developed and covered. So I think there's a task and finish group working on this, hopefully hoping to report by the end of this year, end of 21. That's the end of my report. Thank you.
Great, thank you. Any points, any questions? I don't think I have a question. I just thank you very much for bringing the report. I mean, it's towards the end of the the meeting, and obviously it's been quite a long meeting, but actually the work that's been done, terrible name, place-based partnership. Anyway, that may change in a couple. Don't get too attached to the names, I think, is what I've learnt in the NHS and health situation, because they often change very quickly, is that this work is actually so important in terms of maintaining the joint work in Berkshire West, because of course we are going to be losing our CCG, our commissioning group. That's going to go to the much wider area. I personally think that's a bad idea, but it's going to happen. And so I think this work to hold together a strong and coherent, but most importantly, really well working together group in Berkshire West is really important. And as you can see, the pieces of work that's being done here are really important too. And really look forward to seeing how the joint health and social care funding proposal develops, because continuing healthcare has been a point of some debate, fractiousness, issues, and also it's really important to individuals and residents themselves, isn't it? So I think that's a really important piece of work to develop. So I haven't got anyone else indicating or asking any questions. So that is it. Thank you, Andy. Thanks. Right, okay, so the next item, we're nearly there now, is the integrated programme update. Bev Nicholson.
Hi, Councillor Hoskin, thank you very much. So I'll just share the report. I'm hoping people have been able to read it. Just going to pull it up now. Oh, hasn't shared the right screen, apologies, just bear with me. Let's try that again. There we go. Can everybody see that okay? Is the report showing on screen?
Yes.
Oh, lovely.
Yes, the report is, yeah.
That's fine. I'm not going to go through every page in detail. I'm just going to give you some highlights here. So I hope that's okay. I attached the programme plan as well for the integration board, and that shows an update for Q1, which is April to June, and we are currently updating Q2, which is July to September. So that will come to the January Health and Wellbeing Board. The Better Care Fund national target, which focus mainly is main focus rather of the integration board Better Care Fund projects, shows that we are performing more. I would say poorly, really, against the targets compared to our report last time. We were awaiting the Better Care Fund national targets for 2021-22 to be released. So we're currently working against the 2020-21 targets. In fact, the guidance came out last Friday for the Better Care Fund for this financial year. So the reports I will give you at the moment are based on the 2020-21 targets in the absence of that planning guidance. So you will get an update at the January board on those new targets. So we're on track. Sorry, we're not on track against the non-elective targets, and I'm just going to scroll down to where I've got the charts here. So this is non-elective admissions to hospital. And I was asked the question whether or not this was as a result of the pandemic. And whilst I can't say that for absolute sure, what I have done is included the performance charts from pre-pandemic, so 2019-20, where the targets were not met and we were 4% above the maximum target. And the chart for 2020-21, so last year, during the pandemic, which shows that we met the target. We were actually 12% below the maximum target. And then in 2021-22, so this year, we're actually at the moment, our projected performance is 11% above the maximum projected, the maximum target. However, on a more positive note, you know, when we compare 2019-20 to the projected targets for 2021-22, we've actually reduced the number of non-elective admissions per 100,000 people by 40%. So, you know, I think that's quite good going. I mean, although, you know, it's not great that we're not performing well against the target at the moment, in that 2-year period, we've actually reduced it by quite a significant amount. So moving on now to the residential nursing, that's the one I'm looking at. I'm just going to scroll down now. So this is admissions to residential nursing homes. And again, as I said, based on the metrics we had for 2020-21. And this is looking at data across the first quarter. So in fact, in relation to residential nursing placements, the forecast based on our current performance is going to be 340 placements against a maximum target of 571. So at the moment, we're well within target. And we are being asked to put stretch targets on the metrics for next year, and this is one of the ones that will be remaining. So we may want to consider reducing that maximum target, 571, and that will come to the next Health Wellbeing Board. We're actually not on track again for the reablement target. So this is where people remain at home 91 days after discharge from hospital, where they've entered the reablement service. The target is 93% of people remaining at home. The projections currently are at 84%. When we looked at the data of the people that were admitted in January or discharged from hospital in January and still at home in April, we can see that the target is actually it's below target. We haven't met the target, but sadly 5 people passed away. Now the current way of measuring this data is that we have to include people that are on end of life care or actually can't be reabled. And if we didn't include those people, actually we would have met the target, but obviously we have to meet the national reporting frameworks. So then we move on to discharge to assess. So this is the independent living flats that we have at Charles Claw Court. We're not on target here, but this is due to some very long stays, due to some really complex cases that they've had at the independent living flats. And our social care teams are working really hard to address this. So then we'll move on to the local targets. So this is around our discharge to assess pathways. I'm going to talk a little bit through the average lengths of wait. So this is from people when they're medically optimised for discharge, the lengths of wait they have between being ready to go and actually being discharged. So I have some positive news to report here actually. So on pathway 1, the length of wait was 2.4 days, which is a reduction by 1 day since the last quarter's report. Pathway 2, a slight increase, but only very slight, to 1.5 from 1.4 days. This is people going out to community beds. And then pathway 3, we had a significant reduction here. So these are quite complex cases, and we've gone from 10.6 days in the last quarter right down to 3, which is fantastic. And our, hospital discharge teams have been working really, really hard to improve on that. And this demonstrates that hard work that they've put in. We're continuing to perform very well against the hospital discharge metrics, the local metrics. So on Pathway 0, we've got a target of 75%, above 75%. And our performance is 79% for this quarter. And again, for Pathway 1, it's above 16% is the target. We haven't performed quite so well on that one, slightly below at 15%, but not a million miles away. Pathway 2 is below 8% target, and we're actually on 5%, so doing well. And for Pathway 3, we're at the target. So the ask is that we're below target, below 1%, but actually we're performing at 1% of discharges on that pathway. So, we're doing pretty well really against the hospital discharge pathways. And we're going to be applying the new metrics that have come out with the Better Care Fund planning guidance to the next report. I'm going to move on to residential admissions. After reablement, again, strong performance here. We've had no admissions to residential beds, which is really good. I'm showing you the right, yes I am, I just want to check that I'm showing you the right chart. We've had no admissions in, and that indicates a really effective reablement team supporting people to remain at home and living as independently as possible after discharge from hospital. However, it's true that we have had fewer people accessing the reablement services. We're looking to have a minimum of 1,200 people accessing that service during a year, and our current projections for the year are at 879. So there is an ongoing review of the community reablement team service to look at demand and capacity, and I'm sure that will inform how we move forward in this respect. The reablement team have been really effective actually in enabling people with an average length of stay within reablement services being about 3.3 weeks, or just over 3 weeks, which is fantastic. So well within the national framework period of 6 weeks. So very good performance there. And then the additional funding that we get for the Integrated Better Care Fund is used to support people on community care packages. So this has enabled continuing care and increases in the number of care packages provided, and that really requires, is where ongoing care is required. So we've continued to support that, and they have increased over time. So now I'm going to move on to the engagement. So health